मुंह दिखाई हो गई, मुंह दिखाई.
I know.
कविता मैडम, सब लोग वेट कर रहे हैं ऑल ओवर इंडिया से इंदौर आने का.
सब राहत, सब जो तेजी से सबको बुलाना है बस.
हाँ, we are all waiting.
या खुद को वैक्सीन लग गया. ज्योति मैडम क्या बोल रहे हैं?
ये बोल रही थी हमारी शॉपिंग हो गई थी, तब तो मेरे को शॉपिंग को नहीं ले गई साड़ी की, इसलिए मेरे को वापस आना पड़ रहा है.
अभी आपको मैं फिर से बुला रही हूँ, आ जाओ एकदम. सारे सबको लूट खाएंगे अपन.
गुड इवनिंग एवरीबॉडी. हेमा दीदी, ज्योति दीदी, कविता, यशोधरा, नेहा और कौन दिखता है?
हाय उर्मिला.
हाय.
Good evening, ma'am. Thanks for joining.
My pleasure. अच्छा है ना, थोड़ी चहचहाहट चिड़ियों की सुनाई पड़ती है, नहीं तो फिर क्या. कोरोना में अपने बेसिक काम कर लो अस्पताल के.
ज्योति मैडम तो हॉस्पिटल से बोल रहे हैं अभी. ज्योति मैडम आप चैम्बर में से बोल रहे हो?
मैं चैम्बर में हूँ. हाँ, अभी तो चैम्बर.
घर जाती है क्या कभी?
अरे बहुत कम टाइम के लिए बैठते हैं पंकज, बट टाइमिंग्स आर सच ना कि अपन हमेशा यही मिलते हैं. I'm just doing it 3 hour OPD.
ग्वालियर आता हूँ तब आपके घर मिलते हैं.
हाँ बिल्कुल. पर अभी तो आई एम मूविंग बैक नेक्स्ट वीक पंकज.
Got the confirmation?
Yeah, that university का हो गया gazette notification and everything.
It is a big boon for the organization.
I don't know that, but
I never flatter anybody. I am honest about it. Our Deepika has been made a visiting professor now for fetal medicine in Guwahati. She wants to shift to Delhi, and I told her that it will be a big boon. Fetal medicine department starting with someone like Deepika in Guwahati, it will be a big boon for the patients in Guwahati Medical College as well as the students there. And even I would consider even consultants there. Hema will bear with me. They will learn from this, I'm sure.
Yeah, Pankaj, I agree with you because अभी वो मंदाकिनी प्रधान का मेड जीनोम्स के साथ एक मीटिंग हुआ ना, so I was just there briefly. So I was telling now with Dr. Google, patients know better, so we cannot cut a sorry face. We do better buck up and
absolutely.
Right. Yeah, very right.
Leela, hi. Jyoti, myself and Pankaj Bhai had come to Gwalior 23 years back. Huh?
I know. That was the first time I met both of you, I remember. That was a great time.
पंकज सर उसके बाद भी आए थे शायद मैडम ना?
2-3 बार गया.
पंकज सर तो बहुत बार आए उसके बाद, बट हेमा hasn't come.
और एक बार तो मैं आई, बाद में नहीं आई.
वही मैं बोली, उसके बाद नहीं आए.
Jyoti madam, shall we start now?
Yes, why not?
Shall I start, madam?
Yes, Manisha, please do.
Yeah. Namaskar and good evening. With immense pleasure, I, Dr. Manisha Maheshwari, President Ratlam Society, warmly welcome our guests, faculties, chairpersons and panelists. I humbly welcome members of all obstetric and gynec societies of Madhya Pradesh and attendees of other societies also. Today's session is on very important topic, effects of gestational diabetes mellitus with an ever increasing incidence in Indian population. I am sure we'll have a great learning experience with academicians and teachers sitting here today. It is a proud moment for Ratlam Obstetric Gynec Society to host this virtual meet along with Association of Madhya Pradesh Obstetrics and Gynecological Society, AMPOGS. I welcome honored guest Dr. Jyoti Bindal Ma'am, President AMPOGS. She is ex-Dean CEO MGM Medical College Indore, Member State PCPNDT Committee. She was active member COVID Technical Advisory Committee. I request Dr. Jyoti Bindal Madam to please deliver welcome address. Madam, the floor is yours.
Thank you, Manisha. On behalf of Madhya Pradesh Obstetric Gynec Societies, It's a proud privilege to have such stalwarts with us today. I especially extend a very, very warm welcome to my friend, Dr. Pankaj Desai, Dr. Hema Divakar, Dr. Jaideep Pant is here. I cannot tell you how benefited we are going to be by the presence of Dr. Mulika Pai, Dr. Leela Vyas, and also I think panelists we will have Uday, Dr. Uday Thanamala here. So I can see that he has already joined. I can see Charmila, and of course my colleagues Yashodhara, Kavita, Manisha. Once again, thank you so much for hosting this meet and bringing all these legendary personalities under one umbrella to have the exposure for gestational diabetes, which somehow has become probably one of the most important factors in our obstetric life today. Once again, a very, very warm welcome to all of you, and we are all looking forward to hearing today's sessions. Thank you.
Thank you, ma'am. I also invite and welcome our Vice President AMPOGS, Dr. Yashodhara Gaur, madam. She is professor in Gajre Raje Medical College, Gwalior, past President Gwalior Obstetric and Gynecologic Society 2019-20. She is President MP State Chapter AGOI. Welcome, madam. I take the opportunity to give a brief introduction of guests of honor, though both are very well known to all of us and they don't need any introduction. I invite Dr. Jaideep Tang, sir, Secretary General of FOXY, past President Mumbai Society. He is a thorough gentleman who is working day in and day out very hard with our FOXY President Dr. Alpesh Gandhi, sir. Welcome, sir. I invite Dr. Kavita Bapat, madam, our next guest of honor, our own dynamic and active FOXIan, Vice President-elect FOXY 2021. She is President Indore Menopause Society. She is one-day hysterectomy specialist and Director of Bapat Hospital, Indore. Now I request Dr. Jaideep Tang, sir, to say a few words of wisdom, sir.
Thank you very much, Dr. Monica, for that very kind and extremely generous introduction. I hope I'm audible.
Yes, sir.
Yeah, thank you. It is indeed a great pleasure to be here. This session is being held by the Association of the Madhya Pradesh OBGYN Societies and the Ratlam OBGYN Society. Indeed, what can truly be called the beating heart of India, being the most central state in our country. And of course, it is quite a pleasure to be here. And I would like to thank Dr. Manisha and Neha for their persistent follow-ups as the President and Secretary of the Ratlam Society in ensuring that you have all these very eminent faculties participating in this program. I would also like to thank our very eminent President of the AMPOGS, Dr. Jyoti Bindal, madam, who we have done quite some work with, and Dr. Yashodhara Gaur, madam. It is, of course, a pleasure to be a guest of honor along with Dr. Kavita Bapat, a dear old friend. And Kavita, we are quite looking forward to being in Indore and catching up and meeting everybody. I won't say I'm looking forward to the shopping because most of the shopping is going to be done by my wife, but we are still very much looking forward to Indore. You have really got a fantastic program. It's on gestational diabetes mellitus. We have all heard about the problems of gestational diabetes mellitus in our country, with India being variously called the diabetes capital and the largest number of cases and so on and so forth. And I think we have some leading voices from our fraternity to talk about these topics. Your first session is going to be chaired by Dr. Pankaj Desai, someone whom I always thought has this quite unique ability to think outside the box and be a contrarian and excel at it. In fact, I was delighted to discover that on one of our travels together, Dr. Pankaj Desai and Mimi shared a common taste in literature. And after that, Dr. Pankaj Desai had sent me a couple of books. Sir, I must tell you that the Herman Hesse book you sent me is still lying with me, and I do refer to it off and on. Then, of course, you have Dr. Hema Divakar, someone who has held the flag of Foxy so high, both nationally and internationally. I think I can quite confidently say that some of Foxy's most prestigious projects have taken place because of her initiative, and she is the driving force behind Manyata and the WDF project. So, thank you, madam, for all that you do for Foxy. Then you
Thank
have
you.
the next session, which is going to be chaired by Dr. Leela Vyas, another dynamic personality, someone whom I had the pleasure of working with as the past vice president when she was holding that post in Foxy. And of course, we are all looking forward to hearing one of our most eminent academicians, Dr. Murlidhar Pai. I don't know if you are aware, Dr. Pai, but your name in the program itself means quite a few more delegates to that program. So thank you very much. Looking forward to hearing all of you. And then, of course, there's my dear friend, Dr. Uday Thanawala, another excellent academician who's going to moderate a panel with some fantastic panelists, Charmila, my good friend, Sumitra, Dr. Dolly, and Dr. Jayashri Sridhar. All in all, it's quite a fantastic program, very well designed with really eminent faculties, and I'm delighted that you asked me to come here and share my thoughts with you. I will not stand between you and the wonderful academics that are going to take place, and would end this by simply thanking Dr. Neha, Dr. Manisha, Dr. Jyoti Sindal Madam, Dr. Yashodhara Gorakhpur for having me here. Thank you very much.
Thank you, sir, for your gracious presence. I now invite and request Dr. Kavita Bapat Madam to please address us.
हाय मनीषा, थैंक यू सो मच. मध्य प्रदेश सोसाइटी का प्रोग्राम हो और मुझे ही गेस्ट ऑफ ऑनर बना दिया जाए, दैट इज टू मच ऑफ योर पार्ट. रिस्पेक्टेड ज्योति Yashodhara for heading the AMPOGS is a great thing being done, but I'm really proud of Ratlam OB-GYN Society. इतनी बड़ी गैलरी डाली आज मध्य प्रदेश में. It's just like a cricket team of yesterday. मतलब क्या ही बताएं सबको सबके बारे में, मतलब बोलना भी बात ज्यादा है, but as per my norms, I always like to tell one word about a person. Pankaj Desai sir is a legendary teacher of teachers, and Hema Divakar madam is ultimate. वो gestational diabetes क्या, she can move anything. Whatever जो चीज पकड़ती है वो, then she can make it out. And remaining all the panelists and Murlidhar Pai, everyone is there, and Dr. जयदीप टैंक सर ने अच्छे से उसको डिस्क्राइब कर दिया. सो आई वोंट टेक मच टाइम ऑफ योर्स एंड लेट, क्योंकि लोगों को डॉक्टर पंकज देसाई, हेमा दिवाकर, मुरलीधर पई एंड ऑल पैनलिस्ट सबको सुनना है. सो थैंक यू सो मच वंस अगेन फॉर गिविंग मी दिस चांस. पर इतना बड़ा स्टेज पे मुझे ना बुलाया करो, मैं तुम्हारे साथ हूँ हमेशा. थैंक यू सो मच.
Thank you, madam. Thank you. Now, without taking much time, I would call upon Dr. Neha Saraf, Secretary Ratlam Obstetric Gynec Society, to further continue the scientific session. Dr. Neha?
Thank you, Mr. Thank you so much. It's an honor to welcome all the stalwarts of Foxy. And I today take the privilege of introducing someone as great as Dr. Pankaj Desai, sir. Sir is a consultant OBGYN at Janani Maternity Hospital, Baroda. As we can see on screen, sir has a long CV. But for someone as knowledgeable and as intelligent as sir, even this seems short. Sir has many national and international awards, recognitions, and papers to his fame. He has been a lecturer, moderator, panelist at several conferences. But above all, and most of all, sir is very humble and modest, always full of affection and blessings for everyone. I welcome you, sir, to chair this session, and thank you for accepting our invitation and gracing Ratlam by your presence. To introduce an ever-smiling and charming personality like Dr. Hema Divakar ma'am is an honor for me. Ma'am obviously needs no introduction. Rather, she must have introduced many to Foxy. Ma'am is the medical director at Divakar Specialty Hospital. She's a senior consultant OBGYN, an opinion leader and past president of Foxy, vice chair for Figo PCPND committee. She has got Figo Women Achievers Award, Global Asian of the Year 2018 Award, Excellence in Women's Healthcare, Semi Excellent Award, CSR Times Award, etc., etc., etc. The topic of Hema ma'am's today's talk is gestational diabetes, mellitus, scenario in India. What's done, what's desired. Welcome, ma'am. The stage is all yours now.
Thank you, Neha. Pankaj bhai, should I share my slides and start, or do you have any opening remarks to make? Pankaj, you're muted, Pankaj.
Sir.
Unmute kar do, sir.
Have I to make some remarks?
Sir, I will invite you. I thought maybe after the session.
Okay.
No problem. No problem.
Namaskar, everyone. From the broader umbrella of the All Madhya Pradesh OBGYN Society, we are so happy to see Jyoti ji and Yashodhara ji here with us. And from my own very beloved, lovely people, lovely place, Ratlam, Maheshwari ji, Neha, and my heart-to-heart connect, Leela Joshi, and all the other beloved members, my fellow distinguished speakers, leaders in Foxy and office bearers, Jaydeep, Kavita, and the rest, with a very warm hello from my end also. We bring you to the ground realities of what's done, what's desired, when we have to bridge the gap with innovative thoughts about implementing what ought to be done and the challenges in our own country where the resource constraint is there. But still, we have to, as has been said, move the mountains and get to as close to the quality care as possible with the best available, not coming in the way of what the barriers are, hopping over the challenges and trying to do what we can. So that diversity and vastness of India, as is known to everybody, if we put many countries together, then it becomes one country, India. So people who are overseas cannot even imagine the kind of challenges that our physicians and the teams are grappling in our own country. And we are very well aware that everything is not possible everywhere. As you can see in this picture, amidst such a variety and a volume of patients that a clinician has to deal with in the shortest possible time, diabetes in pregnancy has also added, like a cherry on the cake, another tsunami for presenting yet another greater challenge. You would very clearly see here that we in our country can boast of centers of excellence where in the most cost-effective and the most skilled manner, everything can be available to those who can access, to those who are aware, and those who can afford it. But you will see on the ramp here that the different socioeconomic and cultural and literary backgrounds have to come on a common platform for what we envisage as the universal health coverage. And it is our endeavor to reach every girl, every woman, to make things happen. This is a small illustration about the difference between the West and our own country. You just see the driving in America when things are normal, the driver is driving like that, but when he's drunk, then he goes this way. Whereas in India, the situation is just the reverse. In the normal situation, then you have to go in a devious manner, negotiating all the curves and bends. But when you are not in touch with the reality, yes, you can go on a straight right royal way without recognizing the harm you're doing. So this is a kind of a country, and this is the tsunami which is striking us. And as has been said, we don't want India to become the diabetic capital. We want it to become the diabetic care capital so that people in the other Asian regions will learn from us the innovative Jugaad modules which we have bought in to see how best they can tackle in their own countries. So the recent projections have shown by the IDF that there may be a 50% increase. So already we are grappling with the unsaid, and if the volumes increase, then we really will have a hard time. So we need to get the handle on this problem right now. Luckily for us, when the positioning in Figo as the vice chair of the pregnancy NCD committee, we really persistently, consistently put forth our problems in our countries and said that some restraints and constraints are there. Therefore, the guidelines need to be modified to the extent that it just doesn't lie on the shelves, because we can't do whatever the other parts of the world are doing. But let us do how best and how good we can in our own countries. So a graded or a most feasible, most practical, most pragmatic guideline was laid down into the Figo recommendations and has now been accepted all over. One of the first changes that we brought in is a change in nomenclature. Did she have diabetes before and then she has become pregnant? Then the first time you're testing in pregnancy, so it's gestational diabetes, but actually she is a diabetic who has now become pregnant. So there is no access to her glycemic status before the pregnancy. That being the situation and confusing people, was she previously a diabetic, status unknown, and etc., etc. So we just thought that she is pregnant, her sugar levels are more. So she is a case of high sugar in pregnancy, that is hyperglycemia in pregnancy. Just stick to that definition, that anybody who is pregnant and having a high sugar is a case of hyperglycemia in pregnancy that you have to manage to get her to a euglycemic state for the best outcome for the mother and the child. So the Figo guidelines by the Figo working group, there were assorted variety of people, and you will see me as the lone OBGYN amidst physicians, amidst diabetologists, amidst public health experts, amidst the laboratory personnel and the pharma industry, etc., with the Figo leaders. You see Professor Moshe Hood there, and there were just two of us, one from India, one from China, who constantly were interrupting the discussion, saying, no, this cannot be included because this is not what we can do, etc., etc. So the first of the Figo recommendations was that every single pregnant woman in the Asian, South Asian regions will need the testing, because by ethnicity, if you are an Indian and you're pregnant, you cannot be selective about doing the test for some, not doing the test for the others. When Uday and myself did a preliminary study with the ICOG, then large number of answers were towards selective testing. Only if she has a family history, only if she has had a large child or a loss in the previous pregnancy, we will do this, that, and the other. But today, as how it has been told, these are a set of staff from the Manyata training group, and Tamil Nadu actually has led a leap ahead even in the gestational diabetic care, because Tamil Nadu government was the first one to introduce universal testing with a single step or a one-step procedure, which then got into as DIPSI recommendation, as FOXI recommendation, Government of India recommendation, and finally moving to be included in the Figo recommendations as well. So Uday and others will be happy to know that today we've launched the Bihar batch of Manyata training. Well, when we asked them the question on, would you test every single pregnant woman for her sugar status? A chorus universal answer was yes. So we've come a far way ahead, that people are at least tuned to testing everybody. But how to test, that evoked a number of confusing answers: fasting, not fasting, 7,500, etc. So those confusions still need to be ironed out in both the private and public sector. So when universal testing was first proposed, they said, how do you know, at that time the single step test was not accepted. We said 30 million pregnant women every year. How do you expect them to come fasting? How will you make them come again and again? How will you give the 4 breaks, this, that, and the other? And most importantly, at the time that the test has to be done, that is early and mid pregnancy, just look at the number of bookings. I'm sure that antenatal coverage has improved over the years. One distinct point which I want to bring home to the entire audience is, yes, today in India, because of the government incentives, most of our women in most of the places are delivering in some hospital. Some institutional care is there for delivery. Okay, that means about maybe more than 80-90% are definitely home deliveries have decreased, and 80-90% are delivering in the hospitals. But for 90% institutional deliveries, even today, the NFHS data is showing only 26% of antenatal coverage. Women in pregnancy are not coming for the checkups as expected. So even if you want to do, you have to sensitize the community and the doctors that they need to come in for early booking. So here again, the emphasis on telling them simple things, not confusing their minds. This is accepted, as I said, recommended by DIPSI originally 20 years back, but now Figo, Foxy, Government of India, it is in the guidelines at booking, that is at 12 weeks and at 24 weeks, to do a single step test with 75 gram glucose. It's okay if she is not fasting. It's okay if she is fasting. Saves time, saves cost, avoids repeated visits, and suitable for an Indian setting. And the pickup rate is much more, and it avoids the repeated samples. So here again, you will see a whole team of Manyata nurses. Yes, they say, now we have understood what it is. And unfailingly, they will instruct the patient very meticulously, very correctly about what needs to be done. So what's done, what is desired. We are now coming closer and bridging the gap on what is best to do and whether that's really happening or not. So it's far on a positive tone than years ago. So Figo needed to invent some innovative alternative methodology for testing and care. And one of the most important points before we bought in the diabetic certification course, OBGYNs would think that yes, we have tested. Yes, her sugars are more. Now let her go to a diabetologist. The vision or the thinking that OBGYNs have to take the primary responsibility for this patient came in a little slowly than expected, because necessity is the mother of invention, and we needed to do this in our country, and we got the government sanctions for these recommendations, single step tests, and OBGYNs taking care of these people. Because if really everybody does the test, even if it's a ballpark 10% incidence, now it's of course going more than 15%, but out of 30 million pregnant women, 3 million are identified. Who's going to take care of them? Yeah, ideally, what is desired is a team approach, an obstetrician, a diabetes physician, diabetes educator, dietitian, ultrasonologist, a nurse midwife, or a qualified person who is good at communication, and the pediatrician. But the numbers in our country don't match. For 3 to 5 million pregnant women every year, how can just about 1,000 plus diabetologists take care? So a dietitian, not a luxury anywhere and everywhere. Charmila was a witness to the discussions on pre-pregnancy and pregnancy care, the nutrition and the diabetes care, where people from the institution said, yeah, we send them to the next room because the nutritionist is sitting there and they'll do everything for us. But this definitely, I'm quite sure, not only in Ratlam, but many, many places in the country, inclusive of Bengaluru, it cannot be available everywhere. And diabetologists and physicians, they also have a difference in approach and thinking. So it's a huge barrier. And we again come back to the point that everything is not possible everywhere. So Figo recommends that all countries provide the best of the GDM management that's possible given the available resources. So then what did we embark on doing? We said, if we have to take care, okay, then we have to train the OBGYNs. We have to empower them to handle these cases to the best possible extent as possible. So innovative ways to build capacities and offer alternatives. So multitasking instead of multi-speciality team, one OBGYN doubling up for everything that she has to do for diabetes in pregnancy. So this was the situation about 8-9 years ago, and the practical, pragmatic guideline came into the picture. You will see the group again. again producing a pragmatic guideline for diagnosis, care, and management. You'll see Anil Kapoor from India, who is one of the strongest pillars of support to emphasize that the situation in all countries are quite not the same. So a certification course was introduced, and the master trainers, my champions, all across the length and breadth of the country. Now the courses have gone online as well. So more or less everybody is aware the broad principles of management, which Dr. Muralidhar Pai will eloquently present in a few minutes from now. To produce a DIP clinic kit, diabetes in pregnancy clinic kit, to establish the DIP clinics was the primary vision, so that everything, including diet chart, the monitoring of the weight gain, etc., can be done. But now with the training programs, we have realized we cannot split that one pregnant patient goes into one diabetes chamber and one hypertensive chamber, etc. Everything needs to be integrated. So that is the team approach. That is the integrated antenatal care, where everything, thinking nutrition first, thinking of high risk factors, managing everything under one roof and one umbrella. That's the thing. So the kind of situation is some care is preferred to no care at all. To look back on the situation where we were not even testing and diagnosing, and like ignorance is bliss, not even knowing that these would be at such high risk, not only in the near future, but also for years to come. Both her and her offspring would be under jeopardy, because nobody would have ever known that these were the potential set of mother and baby who are prone to the long-term problems. So the action points which we brought in was to bring in OBGYNs as the central players, as evidenced by today's webinar itself, where all the OBGYNs are our target audience, to learn, to understand more, because there is no escape from this now. We need to be empowered to know more and to do the right thing. So capacity building, multitasking by OBGYNs, and emphasis both on pre-pregnancy and post-pregnancy care, because in pregnancy, yes, there are a lot of things that we need to do, and how to guide the patient to maintain her target blood sugars. That should be the aim. No matter what, whether you do only diet advice and exercise advice, whether you give her the oral medication, whether you give her the insulin, your bottom line is that the target should be met, so that the in utero milieu for the baby is normoglycemic at whatever cost, whatever efforts that you have taken. So this baby is programmed as in any other normoglycemic mother. So we have to implement innovative ideas. So we say that, at least I tell to myself, it's taken me a while to understand that it is not necessary to understand everything. Yeah, because then there is only so much we can do. Then we have to refer to the higher centers, the multi-specialty stakeholders, the expert diabetologists, and of course, a neonatologist is a must. So lastly, in closing, I want to say that in utero programming is a concept which is now come to stay, and it's a reality. So it's a vicious cycle, the karma theory of the intergenerational transmission, pregnancy and increased insulin resistance, so fetal and neonatal metabolic programming. That baby becomes childhood obesity and early adulthood diabetes, and that mother also becomes type 2 diabetes. Just imagine, she's just 22 years old. She's had hyperglycemia in pregnancy. Either you have not tested or you have not given her the long-term advice. By the time she's 25, 26, she's a full-blown type 2 diabetic. This cycle has to be absolutely broken, and the offsprings of these mothers' long-term care, absolutely, the pediatrician also should be sensitized that this baby is born out of a hyperglycemic mother, so that he pays attention to guide the parents to avoid the childhood obesity and the lifestyle changes. Postpartum weight loss, which is a rarity, we have to start paying much and more attention to this, because half the number of type 2 diabetes post-pregnancy can be reduced by just the instruction, serious instruction for the lifestyle change and the weight loss. So we have to involve all the stakeholders. Like we said, it's not one person, it's the whole team, the whole of our community, and everybody involved should have their heads on to integrating, not working in silos, but coming together for a cause and making the efforts amplified to reach every girl, every woman. So this is again another picture where the staff nurses are so passionate, so committed, so involved when they are given the due space and recognition, and they can be multiple helping hands for us to fulfill our aim of bridging the gap between what's desired, and that's what will be also done. With that, let us pledge to make a difference and tackle the GDM tsunami by innovative approaches and have the wise and collective thoughts from all our leaders and stalwarts to make course corrections, to learn lessons as we move ahead. And we must say that together we will make this happen. And what is done and what is desired should never be an issue. We must be able to do whatever we desire. Thank you very much.
Thank you for the crystal clear presentation, ma'am. For sure, together we'll make a difference. I humbly request our chairperson, Dr. Pankaj Desai, sir, to conclude the session by his words of wisdom. Welcome, sir.
Wisdom is what I have been looking for since such a long time. I discussed with Muralidhar also. कहीं मिले तो देना यार. Wisdom नहीं मिल रहा कहीं.
सर कस्तूरी की तरह बाहर नहीं अंदर है आपके.
अंदर भी बहुत ढूंढ किया है. And then in this reference, I am reminded of 8th of November 2020. Does Neha remember that date? 8th of November 2020. That was the date when I conducted a webinar for Ratlam Society. And there were 45, they have 45 members, and they had, and 45 was the attendance. Probably 46 because the person who sponsored and a technical person was also there. Now, you see the effect of your webinars, and this is what this webinar, the way Hema has done it, the coming events cast their shadow, and then after Muralidhar to follow, and then the panel. I am sure it is going the same way. This last Sunday, when I got the statistics of that webinar, 2,948 people had actually seen that webinar on YouTube. Okay, on my channel. So you can imagine the quality of webinars you people are producing in general, in Rajasthan, in Madhya Pradesh, and in Ratlam in particular, and today is no exception. And with someone like Hema coming in and Muralidhar to follow, and such brilliant people thereafter, I am sure it is going to be a great thing. But 1971 is one more date which I would like to recall. And Hema will remember, 1971 was a game changer. If you see the photographs of people, of human beings, Homo sapiens before 1971, anywhere in the world, especially in European and America, and then after now even in India, obesity, as Hema said, is a big epidemic. I handled hardly one obese patient in 5 to 7 years when I was in medical college, and a diabetic patient, a gestational diabetic mother, hardly once, maybe in a year. Now every month, my wife and my team work together. Every month, 108 kilograms, 110 kilograms, so much so that, let me confide in you, that we had to change the operation theater table. And we now have a table which can handle these people easily and bear the weight when they are delivering or when they are having a cesarean section. So Hema was absolutely right when she said that it is a huge problem. It's a major public health problem. And even, you will be surprised to know, and Hema has attacked it correctly, that it is the rural areas where the incidence is nearly 3.5 times, 4.6% in urban areas, 14% in rural areas. It's a staggering of type 2 diabetes mellitus. Wait. And this number is expected to go up to 79.4 million by 2025. Hema was telling something about 2035. This is about diabetes mellitus. Not surprisingly then, in parallel with the increase in diabetes prevalence, the increase in obesity prevalence, gestational diabetes mellitus is also rising. See the swing in incidences. 3.8% in Kashmir. Now I'm talking about GDM. 6.2% in Mysore. 9.5% in Western India. 17.9% in Tamil Nadu. And in more recent studies, using different criteria of prevalence, as high as 35% in Punjab and 41% in Lucknow. Now, this shows that the problem is severe and we have to work for it. It is estimated that about 4 million women are affected by gestational diabetes mellitus at any given point. And therefore the importance and therefore the responsibility of Hema, of Dr. Hema, pardon me now, Dr. Muralidhar and all increases because we have to be prepared for it. And you gave an excellent summary of what efforts are being done at different levels. And I'm now sure that Muralidhar and Dr. Thanawala will now filter it down to the level of the case, as we did it on 8th of November. It will be filtered down to lowest of low, means in a clinical setting, as to how we should do smartly manage diabetes mellitus. And this is what is the message that has come out. And Hema has done a fine job. I thank you all for inviting me here. I thoroughly enjoyed. A little envious of Dr. Pankaj, who had some snacks in between. Unluckily, I could not have it because my daughter just told me, daughter and daughter-in-law both, that Baba, dinner is ready. I have my dinner at around 6 o'clock. Dinner is ready. So I was just waiting for Hema's lecture to get over, and now I will finish. And I'm not diabetic as yet, but I have started making these habits, regular habits, in time. Brilliant lecture, enjoyed it, and I'm sure subsequent sessions also are going to be brilliant. Last, once again, congratulating Ratlam team and Madhya Pradesh in general and Ratlam in particular for bringing about top-class programs. Let's 2,948 views, clicks on that real laparoscopy, that near-death situations which we discussed could not have come. Please continue doing a fine job. And Jaideep and all also are here. God bless you all. I enjoyed thoroughly. Hema, excellent job.
Thank you, sir.
Thank you, sir.
Thank you.
The start, as expected, was superb. Now, for our second session, I, with folded hands, invite Dr. Leela Vyas ma'am to chair. Ma'am is the former senior professor and unit head, IVF consultant, member of Research Review Board, SMS Medical College, Jaipur. She is the senior consultant at Cochrane Hospital, senior consultant aesthetic and cosmetic gynecologic at Vyas Clinic, Jaipur. She is the chairperson of SR Rajasthan, vice president Foxy, president Narchi Rajasthan, president Jaipur OBS and Gynae Society, secretary Jaipur OBS and Gynae Society. Welcome, ma'am. The topic of this talk is management of hyperglycemia in pregnancy, for which I have the reward of inviting our esteemed speaker, Dr. Muralidhar Pai, sir. Mr. Arjun, can I have it? Thank you. Sir is the professor and head Department of OBGYN, KMC Manipal. He is the chairman, Medical Education Committee, South Asia Federation of OBS and Gynae, member Governing Council of ICOG, associate member RCOG UK. I welcome you, sir, to start your talk.
Yeah. Can you unshare your slides so that I can share? Okay. You can see the slides and listen. You can hear me, right?
Yes, sir. The audio and video both are clear.
Yeah, okay. First of all, good evening, everyone. And I would like to thank Dr. Manisha ma'am for inviting me to Ratlam. And hats off to Dr. Hema, who has brought this main issue in our country as well as all over the world to the center stage. And with the wishes and blessings of Dr. Pankaj Desai, sir, I would like to present this talk. Management of hyperglycemia in pregnancy. As Dr. Hema correctly put it, whether it is ODM, that is diabetes before pregnancy, or GDM, that is diabetes which occurred during pregnancy, or it is because of pregnancy, whatever it is, the hyperglycemia is the biggest problem. So we have to manage the hyperglycemia. So this slide will tell you why a strict control of sugars throughout pregnancy is imperative. It is needed to decrease the incidence of maternal ketoacidosis, fetal anomalies, especially in cases of ODM and GDM, that first onset variety which occurs maybe early in pregnancy, macrosomia, which can occur in the GDM variety, death of the fetus, and neonatal morbidity. Why diabetes is such an important thing in pregnancy? It is other way around. Pregnancy is actually a diabetogenic state. The placental hormones such as HPL, estrogen, progesterone, they block the insulin receptors. As a result, there will be insulin resistance. They also increase lipolysis and free fatty acids, as a result of which there will be increased glucose. This increased glucose will ask for more insulin to maintain glucose homeostasis. But what is the flip side of it? It leads to hunger. And again, there will be increased consumption of food and increased glucose. This circle keeps on going. And that's why diabetes is such an important thing in pregnancy. Rather, pregnancy is a diabetogenic state. The treatment options usually are diet plus exercise. I consider this as a default treatment. That means whatever you give thereafter, this will remain. As Dr. Hema put it very nicely, diet and exercise should be integral part of not only management of hyperglycemia in pregnancy throughout our life. To this, you may add drugs. Now, drugs can be oral anti-diabetic drugs, or it can be insulin. Now, we will just look at the default treatment. The diet modification, as far as the Cochrane review is concerned, they have reviewed 11 different dietary advices with 6 different comparisons. I just do not want to read all of them. You know that there are so many types of diets that have come in, and if you Google or if you see the YouTubes, you will really get confused. So what is the ultimate conclusion of the Cochrane review of all these different studies? No significant benefits of the diets investigated. What it means is you can continue to eat whatever you have been eating, but you have to control your portions, and probably you have to control the compositions, about which I'm going to talk a little later. The calories, usually we say for 35 kilocalories with a low BMI, 30 kilocalories with a normal BMI, and probably lesser kilocalories with a high BMI. The problem with pregnancy is we always look after mother as well as the fetus. So you cannot go very low on diet like in a non-pregnant person. So diet composition has to be carbohydrates 50 to 60% because you need ready-made energy, proteins 20%, and fats 25%, and adequate fibers. This is very important, especially in pregnancy, because pregnancy leads on to constipation as well. Now I come to the drugs. The usual dilemma, whether to give OADs or insulin. All of you know, during our undergraduate days, the people of my age would understand this. During my undergraduate days or postgraduates, we always said no for OADs. No drugs, only insulin. But whatever may be the dilemma. The basic questions before any treatment is, what is the problem? And what is the cause of the problem? Can we treat the cause? If we can't treat the cause, at least can we treat the problem? Now, we all know coronavirus is the cause. We can't really treat it, but we can definitely manage the problem, and we have been managing it. So as far as hyperglycemia of pregnancy is concerned, if I ask the same questions, we all know the problem is mainly insulin resistance, not so much of depletion. What is the cause? Of course, the pregnancy hormones. Can we treat the cause? No, unless we deliver her. So can we treat the problem? But of course, yes. So what's the logical treatment? The logical treatment seems to be insulin sensitizers. Having said that, can insulin sensitizers alone manage? No. 30% of the women will require insulin because the hyperglycemia can be so high, which can be detrimental, and to bring it down, we may have to use insulin. I will now take you through a little bit of review of literature to convince ourselves whether OADs can be used as first line of treatment. This is a landmark study, I can say, or landmark publication. Though it is 2008, this is the one which shook the world. Here in this study, they pitched metformin with insulin in the treatment of gestational diabetes. The primary outcomes were severe hyperglycemia was less common with metformin, hypoglycemia rather. All of you know that insulin causes severe hypoglycemia, which is not seen with metformin. And that's very important in pregnancy. Hyperglycemia is dangerous, agreed, but hypoglycemia can be equally dangerous to the fetus. Only perinatal loss was seen incidentally in insulin group. I mean, not much of weightage should be given to this. Other composite complications were similar, whether you used metformin or insulin. The secondary outcomes were interesting. Women in the metformin group had faster accomplishment of glucose targets, similar maternal hypertensive complications, lesser weight gain between the time of enrollment and 36 weeks. All of you know, insulin is like a growth hormone. When you give insulin, no doubt, it brings down the sugars fast, but because it is like a growth hormone, your hunger also increases and you will tend to eat more. So maternal obesity, hence the fetal obesity, was not decreased by insulin. So it was well achieved with metformin group, in metformin group. Greater weight loss between the time of enrollment and postpartum visit. The first line therapy, as far as ACOG guideline 2013, insulin and OADs are equal in efficacy. So based on the previous literature, the ACOG came up with this particular guideline. Either can be used as first line therapy. That's really a good news for all of us. OAD for ODM and GDM. As I said, hyperglycemia is most important, but there can be women who have been diabetic and who have been on OADs before they became pregnant. What to do with them? There is evidence to use OAD in pre-existing diabetes, previous GDM, current impaired glucose tolerance. Larger trials comparing combination reporting on maternal and infant health outcomes and long-term outcomes are of course required. This is another systematic review which again pitched metformin with insulin. The conclusions were metformin is better in terms of glycemic control, safer in terms of preeclampsia incidence, and similar efficacy and safety in terms of neonatal hypoglycemia, the frequency of LGA infants, RDS, phototherapy, and perinatal death. One more article which also concluded no difference in glycemic control between metformin and insulin groups. Those receiving metformin recorded less maternal weight gain, almost similar findings echoed year after year. A number of studies reported lower rates of neonatal hypoglycemia. This is very important. This particular article actually compared two OADs, not OAD with insulin, metformin or glibenclamide. Let us look at the primary outcomes. The composite of neonatal outcomes were seen in 35 of the glibenclamide group and only 18.9 in metformin group, clearly having an upper hand for metformin. The other finding, that is neonatal hypoglycemia in glibenclamide group, was higher. That's because glibenclamide will actually secrete insulin, and that's why there will be more hypoglycemia in the mother, which will be transferred to neonatal as well, versus none in the metformin group. That's exactly why metformin is more user-friendly compared to glibenclamide, especially in pregnancy. Oral medication for the treatment of GDM, the final conclusions in 2017 of Cochrane review, is current choice of OAD therapy appears to be based on good evidence, clinical preference, availability, and neonatal guidelines. Of course, they always put a disclaimer like further research is needed to assess the potential harms of one OAD compared with another. They didn't say OAD is not to be used, but they said the potential harm has to be studied in a long-term studies. Now, hyperglycemia in pregnancy is not just due to GDM. It could be due to continuation of over-diabetes in pregnancy. Hence, insulin is also required if she required it in the past. The threshold for initiating pharmacotherapy in the last slide of Dr. Hema I saw, but nobody probably noticed that it was in blue color. Now, I'm trying to say the criteria old was FBS more than 105 or any value more than 200. But the current ACOG ADA criteria is that anything more than 95 FBS and 1 hour more than 140, 2 hours more than 120. If you can't remember 3 values, just 2 values as Hema has shown, FBS more than 95 and PPBS more than 120, you must start therapy. You can put it in other way. These are the targets as well. When you start OADs or insulin, your target is FBS around 95, PPBS 120. Easy to remember. 2 hours, 120 minutes, 2 hours, 120 milligram per DL. This is how I teach the patients. Classification of OADs, those which enhance insulin secretion, mainly sulfonylureas, and those which overcome insulin resistance, again, mainly biguanides. And then there are others. These others are not tried so much in pregnancy. Coming to sulfonylureas, the first generation had a lot of problems, so they are not used. I'm not going to talk about them also. The second generation is the one which has been extensively studied, and they do not cross the placenta, so no fetal adverse effects. Whereas the last one, glimepiride, secreted in the milk, so avoid in lactating mothers. Glyburate are the ones which have been tested. They act by stimulating secretion of insulin from functional cell mass of pancreas, but at least 30% of functional beta cells should be there. They enhance insulin sensitivity also a little bit. The adverse effects are hypoglycemia, as I've already highlighted, because insulin is released even at low glucose concentrations. Weight gain, that is because insulin is secreted and insulin is like a growth hormone. Nausea, vomiting like any other drugs, constipation, headache, and paresthesias. The dosage starting is 2.5 milligrams in the morning. If target is not reached, add another 2.5 in the morning. And then after 3 to 7 days, repeat the sugars, add 5 milligrams in the evening if needed. But you don't cross 20 milligrams per day. However, we do not use this in Manipal for obvious reasons, which I told you in my previous slides. We are comfortable with metformin. The mechanism action is overcomes the insulin resistance, and it promotes peripheral glucose utilization. It reduces intestinal absorption and production from the liver of the sugars. It does not cause insulin release. That's the most important thing. It does not stimulate the fetal pancreas also to over-secrete insulin. That's why there won't be macrosomia in the babies. The advantages clearly are it is pre-pregnancy control of sugars, whether the lady had diabetes or whether she was infertile, PCOS, you would have used metformin and this person can continue with metformin. Prevention of abortion. Few studies have shown that metformin will prevent it, but the recent studies have shown it's not going to really prevent it. But there is no harm in continuation of metformin in the first trimester, but it will not prevent GDM. However, if she develops GDM, you can restart metformin. There is no severe hyperglycemia, which I have told many times already. The advantages continues: minimal placental crossing, so it does not stimulate fetal pancreas, lesser incidence of macrosomia, and minimal secretion in the breast milk. There are some adverse effects, however, but none of them are serious enough to stop metformin. They are very simple ones like anorexia, bloating, nausea, metallic taste, diarrhea, vitamin B12 deficiency. These are in the initial days. Once the body gets used to it, they won't have these problems. What is the dosage? The starting dosage is 500 milligrams in the morning. After 3 to 7 days, you can add another 500 milligrams in the evening if needed, and increments of 500 milligrams, but the maximum is 2000 milligrams per day. So contraindications: hypotensive states, alcoholism, it will have disulfiram-like reactions, severe respiratory hepatic renal diseases, because everything is metabolized in the liver, and of course in the heart failure. The general advantages of all OADs is that they are convenient because they are oral, no multiple injections, no pain, no need of refrigeration. Cheaper, that's why wider acceptance. Do not cause maternal obesity, except maybe glycerides. Promote weight loss, especially with metformin. They do not cause fetal macrosomia, especially metformin again. There are some concerns. They are all minor. Transplacental passage, minimal. Fetal teratogenesis, almost none. Hypoglycemia, mainly with glycerides. And hyperbilirubinemia, not so severe. And polycythemia, again, very rare. Having talked so much, are we using? Yes, we have had our own experience, which is already presented. The conclusions only I'm going to talk. Maternal and neonatal outcomes are comparable whether the patients are treated with diet alone, metformin, or insulin. The most important thing is control of sugars than the way it is controlled. Metformin being oral, cheaper, convenient, it may be used in cases where diet alone is not enough and sugars are not very high, asking for insulin. So when should we hospitalize a patient? It is to start insulin therapy. As I told you, 30% of patients on metformin may require insulin therapy. It is also needed to manage ketoacidosis, hypoglycemic coma, severe polyhydramnias, development of preeclampsia, and of course, around 37 completed weeks where we want to plan the delivery. Now I turn to insulin therapy. Insulin therapy has been the toughest challenge for an obstetrician. We usually refer them to physicians and they usually make fun of us. It is not so easy, not so difficult. I hope after this talk, you will realize that we can ourselves manage the patients with insulin therapy. 30% of women require it. Regimens should be adapted to treatment goals, lifestyle and diet habits, age and general health, motivation and capacity of self-management, social and financial circumstances. What is the dose? Nobody knows the exact dose of insulin. It's always with trial and error. That's why we can have a rough guidance, like first trimester 0.7 per kg, second 0.8, third is 0.9, and at term 1. But this also looks very high dosage to start with. So 20 to 32 weeks, insulin requirement physiologically increases up to 50% of the initial dose. We must keep this in mind whenever we start. In Manipal, traditionally, we have been, from my postgraduate days, we have been using this method. We start with the lowest possible dose of a rapid-acting Actrapid 444 units, pre-breakfast, pre-lunch, and pre-dinner. This, of course, after doing the sugar profile. Sugar profile consists of fasting, post-breakfast, post-lunch, and post-dinner. Then we keep titrating the dosage as per the sugar profile done twice a week. So it may be 484 or 486 or 888, something like that. So once the target sugars are achieved, that is fasting 95 and postprandial 120, we would like to convert these 3 injections into 2 injections, and we will convert Actrapid into mixed start, which contains 30 rapid acting and 70 isophane, so that we can give twice a day. And how do we give that? 2/3 in the morning and 1/3 in the evening. What is the logic behind this? The logic behind this is we must simulate the physiological insulin output in the body. That is 2 peaks and 2 plateaus. What are the 2 peaks? 1 peak in the morning. This is by genetic memory, but this has been changed now by our eating habits. We eat in the morning, we eat in the afternoon, we eat in the night also. But in our ancestors ate largely in the morning and little bit in the evening, because they were going to the field and they were working like that. So that memory is still persisting in us. So first peak in the morning is created by the rapid acting insulin, which is 2/3 in the mixed start. And then the plateau is maintained by the isophane. The evening, 1/3 we give, which also contains 30% of rapid, which will create the second peak, and the isophane will create the second plateau. So this is the logic of giving 2/3 in the morning and 1/3 in the evening. But recently, I discussed this with our endocrinologist. She told me that starting with 444 is okay, but she would like to give a post-dinner isophane of 4 units. She doesn't believe in giving 2/3, 1/3, even though this asks for 4 injections per day. Her logic is there are 3 peaks. As I told you, now our food habits have changed. There's a peak in the morning, there's a peak in the afternoon, there's a peak in the night. And all the 3 times we eat very nicely. So that's why she said the peaks have to be managed by Actrapid 444, but the whole night has to be managed by the isophane, because the fasting hyperglycemia is not because of the food. I will repeat this sentence. Fasting hyperglycemia is not because of the food. It is because of the production in the body, in the liver. So that will be taken care of by isophane. This is the new thing which I learned from the endocrinologist. And of course, FBS is managed by that isophane. So it has 4 injections, but according to her, this is the best way we can manage. Insulin analogs. The physicians are very fond of analogs. They want to try new things. They are increased convenience of insulin therapy, greater acceptance and compliance resulting in a better outcomes, and no major safety concerns with them, reasonable to continue insulin glargine to achieve excellent glycemic control. Good evidence to use insulin detimer as the first-line long-acting analog in pregnancy. There is no problem if you use a long-acting one, because it will not create sudden hypoglycemia. That's our worry. But lack of definitive fetal benefit means that there are no strong need to switch a woman who is well controlled in NPH. Just because the physician wants to change over to analogs, you don't have to do that if she's happy with NPH insulin. There seems little justification in using long-acting insulin analogs where the risk of hyperglycemia is very low. It's basically fancy. Insulin analogs, as far as NICE guideline is concerned, their wordings are be aware, not beware. Be aware that data from clinical trials and other sources do not suggest that the rapid-acting insulin analogs, that is Aspart and Lispro, adversely affect the pregnancy or the health fetus or newborn baby. Use isophane insulin as the first choice for long-acting insulin during pregnancy. Consider, see the wording, consider continuing treatment with long-acting insulin analogs, detimer or glargine, in women with diabetes who have established good blood control before pregnancy. If they have been using before pregnancy, you can continue. But there is no need to switch over from our isophane to analogs. How do you manage the intrapartum period? Intrapartum labor is a glucose lowering, labor has a glucose lowering effect, so lower insulin is required. The latent phase is managed by maternal metabolic demands are minimal, sufficient insulin produced to maintain euglycemia, whereas in the active phase, there is intense exercise with increased energy requirement. Hepatic glycogen stores are rapidly depleted in this active phase. So what are our targets? Ideal target not clear as neonatal metabolic outcomes depend on many factors, but ACOG, NICE, they have told us the target is somewhere between 72 to 126. You must maintain at that level. The levels above 180 are associated with fetal hypoxemia and acidosis, neonatal hypoglycemia, and maternal ketoacidosis. So that's exactly why up to 180 you can be safe, but after 180 you must start insulin. On the day of delivery or a planned cesarean or an induction, what do? Skip the morning dose of insulin. 5% dextrose with neutralizing dose of insulin 6 units is started. GRBS is done every 2 to 4 hours. Urine ketones also done at the end of every pint. If the patient comes in labor after the morning dose, just suspend the insulin regimen from that particular point of time. What we do, we add 1 additional unit to the drip for every rise of 10 milligrams per DL over and above 180. As I told you in my previous slide, up to 180, there is no need of worrying at all. The neutralizing insulin 6 units, what is there in the drip is good enough. But if the sugars are more than 180, for every rise of 10, we have to add 1 additional unit. Subcutaneous regime, 1 unit given subcutaneously if for each 20 milligram increase in the glucose above 120. This is the subcutaneous regime. We don't follow this in Manipal. Postpartum management. Post-operatively, insulin requirement drops swiftly. This has to be remembered. We use the same 5% dextrose with neutralizing dose of insulin 6 units. GRBS is urine ketones at the end of every pint. 1 additional unit to the drip, same as we did during the labor, that is over and above 180. For example, if GRBS is 200, 6 is already there in the drip, you add 2 units to the pint. That means totally 8 units. If urine ketones are present, you give 10 units subcutaneously. This is not the subcutaneous regime. This is over and above what we give in the drip. Once the orals are started, titrate insulin as per GRBS. Usually they require 1/3 to half of their pre-delivery dose. This is the standard. Watch for fall of sugar levels. Switch over to metformin when you are about to discharge them because they would prefer that. Strongly encouraged to breastfeed for its benefits, plus mother can lose weight as well. As far as NICE guidelines, offer lifestyle advice, encourage breastfeeding, offer FBS at 6 to 13 weeks, or you can do a HbA1c at 13 weeks. You can also do a 75 gram 2-hour OGTT. Offer annual HbA1c because 15% of these women can develop type 2 diabetes later in life. The newer technologies, 1 or 2 slides and I'll wind up. Continuous glucose monitoring, transdermal glucose electrodes, microdialysis, open flow microperfusion, so many things are available. The transdermal is very popular and the picture will be something like this, very scary. But reliability is concerned, they are still experimental and not a routine clinical tool. Problems for adjustment of therapy due to wide variability in day-to-day glucose levels of pregnant with diabetes mellitus. So fine-tuning of insulin regimens based on 3-day measurements with the continuous glucose monitoring method is not advisable. So it is still for the non-pregnant women. What about continuous subcutaneous infusion? It is most are GDMs usually diagnosed in the 3rd trimester. So disadvantages are severe hyperglycemia, a high rate of ketoacidosis, infection at the infusion site, insulin pump, and the supplies cost nearly $5,000, which is not affordable. Infusion set, catheters must be renewed regularly, which greatly contributes to the cost. So it's not for us. The future, of course, is a closed loop system something like an artificial pancreas, but there are so many criteria to be met for an ideal artificial pancreas. Safe delivery device that stores and releases insulin reliably and accurately, an accurate biocompatible glucose sensing unit capable of frequent and continuous sampling, a control system that modulates delivery of insulin. So we must be thankful that we have pancreas. So artificial pancreas is so very cumbersome and expensive. Operate correctly all the time to avoid errors leading to severe hypo or hyperglycemia. So with that, I complete my talk and I'll be happy to answer if there are any questions.
Thank you, sir, for this knowledge-packed lecture. There are questions in the chat box, but the chat box is full of compliments for you and
thank you,
Hema ma'am. Choose out the questions and we'll take the questions later, sir.
Yeah.
Meanwhile, I'll request the respected dear chairperson, Dr. Leela Vyas ma'am, to please conclude the session. Welcome, ma'am.
At the outset, I congratulate Dr. Pai. As usual, his lecture for the students, they mesmerized to listen him. And he has covered everything. Dr. Pai, you have rightly said that. Why to refer to the physician and wait for them to come and then start insulin? My suggestion was always to my resident, when you can monitor the oxytocin to prevent the rupture of uterus, why can't you monitor that insulin management? So diabetics can be managed by the obstetrician very nicely, and every tips you have given. And I am also in favor of that, not with the endocrinologist, all physicians, and we have practically seen that the 4 doses are better. Means 4-4-4 means the initial dose start. So pre-breakfast, pre-lunch, pre-dinner, and then post-dinner 2 hours, we used to see the sugar and give the long acting in the night. So the breakfast, the fasting sugar is always corrected in a way. So patients, and sometimes they are feeling hunger, and although they are also eating in the morning, early morning as they are taking. So everything you have covered. So there is no need to just to waste time to repeating all these things. And very nicely you have covered these all newer modalities, because we are getting now the patients, those who are having either the juvenile diabetes or with the diabetes pre-pregnancy, they are coming with the all insulin pumps and then. So it's my request to all juniors and all resident doctors that you should have knowledge about that, because you have to monitor at that time. You can't call every time the endocrinologist or their technician to come and manage that. So you should have all these knowledge. And definitely this is the burning point. This is all the huge problem to us, and we have to take care of these cavities. Thank you very much, Dr. Pai. And Hema always just give one, I'll say a current to every obstetrician that GDM is to be in your priority rather than going the different tests. It is the most important test. We can preventing the next generation, and it becomes our responsibility to prevent the next generation from this diabetes. Thank you, Ratlam Society, for inviting me, and thank you very much.
Thank you.
Thank you.
I just want to clarify. I saw one question that somebody has asked whether it is 10 or 20. So 20 is for the subcutaneous regime. We don't follow that. I said for every raise of 10, 1 unit to be added to the drip. So up to 180, that's 6 units what is there in the drip, neutralizing is good enough. If it is 190, 6 plus 1, 200, 6 plus 2, 210, 6 plus 3, like that.
Thank you, sir. As the temperature has started rising after Makar Sankranti, similarly is the number of our attendees increasing. And I hope everyone is enjoying. Thank you everyone for joining in. To increase the knowledge fever, we now start our panel, Practice Points in Diabetes, before, during, and after pregnancy. To start the panel, I invite our Santa Claus, Dr. Udit Hanawala, sir. Sir is MD DGO FCPS DNT, consultant obstetrician and gynecologist at Navi Mumbai. He is the chairman-elect of ICOG, vice president FOXY 2015, treasurer of PCOS Society, chairperson Medical Disorders Pregnancy Committee, founder secretary and past president of Navi Mumbai Obstetric and Gynec Society, joint secretary FOXY 2005. He's a gold medalist and His special interests are in ultrasonography, maternal medicine, fetal medicine, and high-risk pregnancy. Welcome, sir. Ever wondered why I referred sir as Santa? Because sir is here with his bag of knowledge, from which he will be distributing his gifts of practical points to each one of us here. And to help him with this, we have 4 wonderful panelists with us today. The bundle of knowledge, Dr. Charmina ma'am, welcome ma'am. The ever smiling and soft, Dr. Sumitra Yadav ma'am. Our dear and dynamic, Dr. Dolly Mehra ma'am. Dr. Jayashree Sridhar ma'am, one lady full of passion for OBGYN. I request Dr. Uday Thanawala sir to take over. Welcome sir and welcome all the panelists.
Thank you.
Thank you very much, Neha, and thank Dr. Manisha and the whole of Madhya Pradesh Society, Dr. Jyoti Bindal and all. It was great to see a couple of people whom we haven't met for a very long time. It's wonderful to be here, invited by the Ratlam Society for this wonderful event on GDM. So I think I should share my screen, and I was told there'll be about half an hour, but I think we have a little more time than that, so we can probably take it a little easy. I was just told it'll be half an hour for the panel, but let's discuss some practical points in HIP now. Like Dr. Pankaj Desai said, that from the talks, let's get down to the basics now. When a patient is in front of you, what do you do? And thank you very much, Ratlam OBGYN Society, to be here. And the thing I remember about Ratlam when going from Bombay to Delhi by train is the save, which was fantastic, and the food, which was great. So when I looked up the Ratlam Society or Ratlam on the Google Maps, what comes up is the food deliveries and the restaurants, and of course comes up the hospital, which is bang over there in front of you. So it's so nice to have Dr. Maheshwari here, who's organizing this program and the president of the Ratlam Society. And of course, we welcome our panelists, Dr. Charmila, Dr. Sumitra, Dr. Jayashree, and I think
Dolly.
Dr. Dolly's name is there, but I think it's got a little covered in this. So let me just take it down. Yes, so Dr. Dolly Mehra, who is from Ratlam anyway. So let's discuss what we actually do in practice. And Muralidhar Pai took a wonderful lecture about how to manage the sugar part. So we will just touch upon that. We will not go into great details upon that. Let's discuss some clinical situations on what is happening, because we know that GDM is a very important thing. It has thrown the spotlight on our obstetricians. We are in the spotlight because here is a big chunk of NCDs which is increasing, and we obstetricians are the ones who are responsible now to manage this new patient, the fetus in utero. And if we take care of the fetus in utero, the next generation will not have these NCDs like diabetes and cardiac disease, because pregnancy is a window for opportunity. So let's start with that. And of course, let's take the first case. And the question is to Charmila. We have this 25-year-old PCOS patient with a BMI who weighs 82 kgs with a BMI of 32.9. She's undergoing ovulation induction for infertility with you. Charmila, how are you going to counsel her? What are you going to investigate her? And what advice and drugs will you advise to her?
Actually, sir, good evening, sir. Thank you for that. Actually, we should not start any treatment for such a patient before you counsel her, because she needs to understand that she's an obese person and already she's become polycystic ovarian disease. So the repercussions will be there for her as well as the baby if she's not going to lose weight and then consider a pregnancy. And when she loses weight, it's going to benefit her as well as a baby. The benefit for her will be during the pregnancy, the complications are going to be much lesser. And the intergenerational transfer, which you said, to the fetus is going to be reduced if she loses weight and then she conceives. And the investigations I'll do is, depending on the Rotterdam's criteria, I'll rule out the other cause of anovulation, which will be thyroid function test, a prolactin test, a CBC, and then I will do a glucose challenge. I'll do actually a blood sugar screening because she's an obese PCOS, and I would actually have taken a history for insulin resistance also. The way they sleep after eating and sudden craving for food even after they have taken a good breakfast or lunch, the snoring which happens with PCOS, all these symptoms are maybe due to insulin resistance, and you have to check out for acanthosis. That itself will indicate that she's going for insulin resistance, but a glucose challenge test is a must. And I do a 75-gram 2-hour post glucose to check out whether she's glucose intolerant or she's already a diabetic. So once that is done and she loses her weight, then only the treatment for ovulation induction will start, not before that. And for that, you have to sit and talk to her the diet, which most of them don't accept. They always keep on saying, I eat less, but you have to sit down, talk to them and make it very clear. And when you talk about the problems to the baby, the acceptance seems to be much better than just talking about diet alone.
Yeah, so right now she's just trying to become pregnant and very keen that, no, what the hell, just get me pregnant. You know, I've been married for 2-3 years and now, I'm doing my best and I'm trying to lose weight and all. But I think it is important for us to make them aware. And like you very rightly said, that there is an effect which obesity has on fertility. Plus, when you become pregnant, this obesity will again create a problem in pregnancy. So you need to first get into shape, and then go. Any comments from any of the other panelists if they want to chip in something?
Yeah, we just need to look. Yeah, this obese patients are of course at a higher risk, but this this new concept of this MODI, this maturity onset diabetes of the young, this is becoming a huge pandemic. It's not that rare as it is described earlier. So we are seeing these people frequently with just a history of we need to pick them up in this stage. This is the right stage so that we prevent the fetal hyperinsulinemia from happening.
So please remember that even a PCOS is linked to GDM and that patient could have a sugar abnormality. In fact, initially for young girls, we never used to bother to do the sugar also, but it is important to do it in this case and probably do a proper oral GTT to find out if she's already a diabetic. So you'll be surprised to find many young girls already being a diabetic and with a high HbA1c. So you need to get that HbA1c in control before she becomes pregnant. So there's an importance of diet and exercise, and tell her it's a lifestyle change for you, and that's going to help to manage your infertility. Plus, it's going to go a long way to help you in having a smooth pregnancy.
There's another thing.
Yeah,
there is another thing, sir, that you have to always ask a history of diabetes, because if they have a history, they listen to you more attentively and they start following your orders, because PCOS we know is associated with it.
Yes. Very true. So, and then there are drugs which may help you, metformin or inositols and folic acid. Do you people use this drug, Charmila, in infertility practice?
If she is insulin resistant, I will start her on metformin, sir. Glucose challenge test tell us, suppose she has got acanthosis, I will start her on metformin. But unless indicated, I do not give. If she's got not, but usually they have some form of insulin resistance, and you need to give folic acid. That I give always.
Yeah. So anybody else that use on inositols and metformin?
Yeah, I think almost everybody would be using.
So inositols, I think, are very frequently used, especially for young girls with PCO, because it has some room for benefiting the fertility part by increasing the quality of the eggs, etc. in IVF, but also bringing down a little bit of insulin resistance. And maybe the way I tell my patients that it makes your ovary more sensitive, so you may ovulate better. So either metformin, inositols, etc. can be probably used.
And the acceptance for inositol is better for a younger patient because it considers a food supplement. So if you can say that it's not a drug and it's only a food supplement, they usually take it much, like the compliance seems to be much better compared to metformin.
So basically, preconceptional care is very important because they should not be getting pregnant if their HbA1c is high. or if they are a diabetic. Now, this slide is particularly for people who already have an abnormal sugar, and they should establish a good glycemic control before they become pregnant, and this will reduce the risk of all the complications which we have, like miscarriage, congenital malformation, etc. In the pregnancy, and this has to be explained to the patient very categorically. Okay, badai ho. Now the patient has become pregnant. Now she's come to you with a positive pregnancy test. Now, can you prevent development of hyperglycemia in this pregnancy? If so, how will you go about it? And if on metformin, will you continue it? Dr. Dolly Mehra, please.
Yeah, sir. If she is a PCO and we know that we have put her up on metformin, we will allow her to continue with metformin, and of course check her blood sugar levels and accordingly counsel her that the blood sugar levels have to be within normal limits. Otherwise, during this early pregnancy, there can be development of anomalies, multiple malformations, which have to be kept into control. So we will continue with metformin, as well as we will counsel her for diet control and exercise, because otherwise, if the sugar levels are high, there can be possibilities of fetal anomalies in the fetus during early hyperglycemia.
So even now we heard Dr. Muralidhar Pai, who said that yes, metformin, if she's got an abnormal sugar, continue it. Otherwise, you can stop it and probably restart in case she gets a high sugar later on during pregnancy. So that's a little bit of a question mark, because many people are not in favor of continuing metformin in the first trimester. But in general, in clinical practice, we all, for our infertility patients who are on metformin, we do not stop it when we try and continue it for the first 3 months at least. So metformin and inositols can be continued, and inositols, there is some evidence which is coming up that there is definitely, it may prevent development of GDM in this particular patients if these women are put on inositol. So there is a little bit of evidence coming up for that. But yes, we need larger studies to substantiate it, that women on inositol, the incidence of gestational diabetes may be reduced if it is continued. So that is as far as prevention will go. When will you order a GCT, Dr. Sumitra Yadav?
The moment like she has become pregnant, we'll catch this opportunity, and at the very first visit, because her BMI is raised, because as Dr. Divakar has already told the importance of universal screening, and in our previous lecture also Dr. Pai has stressed upon it, we'll get a DIPSI done, and this DIPSI has been recommended by our Ministry of Health also and by WHO. You have to do at the first visit, and then again you have to repeat in the second. You can easily repeat at the second and third trimester. It needn't be on a fasting woman. It can be done anytime. All you need to do is you have to give 75 grams of glucose, irrespective of her previous meal or fasting, and a 2-hour reading of blood glucose is taken. If it is raised, that is more than or equal to 140, definitely you'll have to give her treatment or counsel regarding her diet, exercise, and all that.
So this is important. It is not only this particular woman which we are going to do the DIPSI test, or we are going to screen for
universal.
It's going to be in every pregnant patient which presents to you. Do a universal screening, and that is now come in the Figo guidelines, as Dr. Hema Divakar has already said. And the 2-hour reading of blood glucose after 75 gram of glucose is done, and it is done thrice in pregnancy. Now, this girl's DIPSI test has come to 134 milligram per deciliter. What is the counseling you will give her on diet and exercise, and what advice on weight gain will you give her, Dr. Jayashri Sridhar?
Yeah, I don't want to sound pessimistic, but this patient with such a huge BMI, it's really a losing battle, So we'll have to, catch all the positive points we can and counsel her.
But why do you say it's a losing battle? Her DIPSI test is normal. It is 134.
So we need to be very, we need to be really judicious when you're explaining to her regarding the prognosis. She's on the first visit, so we need to, you know, be cautious and tell her that, you know, your weight is high and your deficit has come as 134. So we don't, you know, her weight gain should not be the optimum 10 to 15 kg, but only 5 to 10 kg. But we need to ask her to lose weight. That could cause ketoacidosis. So we have to tell her to eat right, like, you know, to avoid hyperglycemia, but also avoid ketoacidosis, and the right amount
But
of
she is not a diabetic. Her DIPSI test has come normal. It is below 140. यहाँ तो मैडम अभी तो इतनी मुश्किल से प्रेग्नेंट हुई, बधाई का मौसम है, मैं लड्डू वड्डू नहीं खाऊंगी तो क्या खाऊंगी? मेरे फैमिली तो बोलती है अभी तो प्रेग्नेंट होगी तो ज्यादा खा, मिठाई खा, दो के लिए खा, और आप मेरे को बोलते हैं खाना बंद कर दो, मेरा टेस्ट तो नॉर्मल आया है ना.
We have to tell her that, you know, we need to avoid hyperglycemia at any cost, because in that case, you know, half the battle of this whole GDM is in the first trimester, I believe, because once her weight gain is very high or her hyperglycemia increases in the earlier on phase, if we miss the bus at this stage, then fetal hyperinsulinemia has already set in, you know, because the fetal mass index.
But the sugar is normal. Why do you want to scare that poor girl? I agree with you. No, what you're saying is absolutely right. But technically speaking, her sugar has come between less than 140. But we have to take the group which is between 130 and 140 very seriously, because these are the girls who will later on develop a sugar abnormality.
Yeah.
So we have to be very cautious. You're very right when you talked about the weight gain. Now, this girl is already overweight. So, you know, she can't put on too much of weight. So we have to counsel the woman according to what her pre-pregnancy weight is. Now here she's of course has a high BMI. So we're going to tell her, okay, don't put on more than 5 to 9 kgs like you correctly said. But for an average weight woman with a sugar of 134, well, maybe your counseling will be a little different if she was an average weight. But of course, you're going to warn her that, look, your sugar is not totally in the normal range. And you know what patients tell you? नहीं, you know, पहले दिन मैंने जरा ज़्यादा रसगुल्ले खा लिए थे, फिर मैंने glucose test किया, इसलिए मेरा sugar high है. It's so typical. So you tell them that, look, if this glucose load was taken by anybody who has a normal glucose metabolism, they will bring down the sugar to less than 140 or even less than 130, but 140 is the technical range. Your sugar has come between 130 and 140, so you are not a diabetic as yet, but you are at a slight risk of having an abnormal glucose. So it is better that you start cutting down your sugar or be very careful of what you eat and how much weight do you put on. Do the panelists agree with this?
Yes, sir.
Yes, sir.
Absolutely.
So
Yes,
the
sir.
weight gain is important to counsel a woman. A woman who is underweight, of course, she can put on more kgs, 12 to 18 kgs, but otherwise the expected weight gain differs according to what they are. Not everybody should put on 15 kgs in pregnancy. Okay, let's go on to another situation. A 32-year-old patient, gravida 2, para 1, abortion 0, with a history of previous full-term stillbirth 3 years back, comes for a visit at 7 weeks of pregnancy. Charmina, her GCT has come as 190. What is the next step will you do and how will you proceed?
She seems to be a diabetic already, and that could have been a reason for the stillbirth earlier on. But now we need to do a HbA1c to see whether she was a diabetic even before she started her pregnancy.
Okay, her HbA1c has come as 8.6.
She's
now,
a diabetic.
Advice.
She has to be labeled as a diabetic, and the management has to start all nutrition therapy, exercise, as well as I would rather start her on insulin, but no termination, because we know that HbA1c of more than 6.5 has got a higher incidence of anomalies, but that's not 100%. It can be around 25% when it's more than 10, and around 8.5, it may be somewhere around 5% only. So, but a surveillance has to be properly planned now, because she's going to be prone for all the complications of diabetes in pregnancy. So the fetal surveillance and the maternal surveillance has to be planned very clearly, and she has to be counseled totally that her management has to be very, very correct from now on, because to avoid the other complications of diabetes in pregnancy.
Yeah, so excellent. So what Charmila said is absolutely correct. We don't really advise termination, but we tell them that your HbA1c is high, your baby is now undergoing organogenesis. This high sugar may cause a problem in that, and we may have some abnormalities coming up like sacral agenesis, congenital heart disease, etc. in the baby. But today, with the ultrasound and the technology available to us, we have a very good pickup rate of these abnormalities. So we may be able to tell you at around 12 to 14 weeks that no, this baby has a problem, or at least at around 18 to 20 weeks, we'll be able to identify the problem and warn you. If there's a problem, we can always offer you a termination. So if you want to continue, you can continue, but there is definitely a slight risk of chromosomal abnormalities. Do all the panelists agree with this? And I think it is correct. If you want to bring the sugar very control very fast, you would probably start with insulin with a high level of around 190 to 200. All the panelists agree with this?
Yes, absolutely.
Okay. So what about the evaluation? Now, this patient, Dr. Dolly Mehra, is going on in pregnancy. And how will you evaluate in her first trimester? What all investigations will you do in the first trimester? We've done a glucose test. What other things we do to screen the fetus and to monitor the fetus? Dr. Dolly Mehra is there? I don't see her. Anybody else can take it? Dr. Sumitra?
Yeah. In the first trimester, because these women are very prone for developing congenital malformations of the CVS, as well as CNS and spinal and of the neural tube defects. So we must get an anomaly scan done at 11 to 13 weeks. And the nuchal thickness is measured and the cardiac evaluation is done very properly. Preferably, this should be done by an expert. And the uterine artery Doppler should be measured, because these people, women with diabetes, are more prone for developing PIH also in this. And because of the fluctuations in the blood sugar, there can be a lot of problems with the test that we are doing. We must get a double marker done. And in these women, especially in women with type 2 diabetes, as compared to non-diabetic women, the PAPE test is not normal. So there can be a false positive combined testing, and therefore, if it is positive, before declaring anything, get a NIPT done, and then only think of any test that is to be done.
Okay. I wanted to add something. There can be anomaly like single uterine artery.
Okay.
At this particular moment, you can also see a single uterine artery indicating towards a cardiac anomaly. You should see for the intracranial translucency indicating towards the neural tube defects at this particular NT scan. That is the first trimester scan.
Yeah, so the pickup of abnormalities is almost 80% in the 12 to 14 week scan. Most of the abnormalities, 85% of the abnormalities can be picked up at that particular scan. So it's important an expert does it, and even the fetal cardiac anomalies can be picked up to a very good extent of 80 to 85%. So one expert has to do the scan and get a scan done from an expert to rule out any structural abnormalities. Uterine artery Doppler we routinely do at this time to find out if it's abnormal. One can start aspirin in these women. And the double marker test, what Dr. Sumitra was saying is that you can when you fill up the form, please mention she's a diabetic. Offer it to the patient. If she chooses to do a double marker test, please mention that that this patient is a diabetic, because the lab has to put a corrective correction in their machine to give you a proper positive or a negative result, or a proper risk factor. So that's about the double marker test. When you are doing for diabetics, please remember to mention that the patient is a diabetic. Then after that, of course, we go on to the second trimester. Dr. Sumitra Yadav, can you also take this up?
Yes, sir. Basically, if, to rule out all the malformations, this is the best window that we can have, that is 18 to 20 weeks. And this anomaly scan should again be done by a very senior expert. And after that, you must always get a fetal echo done. If you are suspecting if the NT was enlarged, was more than normal, in these cases, there is every possibility that there can be a risk, there can be an anomaly in the baby. So in these cases, because we know cardiac anomalies are common, But fetal echo is to be done at 24 weeks, around 24 weeks. And there you can find out lot many things, like if there is any cardiac anomaly, if there is TGA, these all things can be picked up by experts. But if you have already picked it up at 18 to 20 weeks, you can be sure of this. You must always have in the second trimester 4 weekly scans from 28 weeks for finding out the abdominal circumference. And this should be always plotted on a growth chart, because if the abdominal circumference is more than 95% of the normal, strongly suspect, you can almost think that the macrosomia is there, because the shoulder pads and the abdomen are being covered with fat. You should always see the liquor, because the liquor can be either less or more. Remember, when the abdominal circumference is less, that is more ominous also, because it's a restricted growth. In such cases, umbilical artery Doppler is of help in predicting.
We'll come to
whether
that. Excellent, excellent. I think she's covered all the points, and we can go on for the third case. Primey was screened negative in the first trimester. Now she was a low risk primey, 26-year-old. On the 26 weeks, she was when she was screened for GCT, it came to 188. Then how do you counsel this woman, Dr. Jayashree?
So my first trimester counseling, how much ever I scared her, probably is come to a knot. Like her 75-gram GCT is 188. So now I'll have to make her accept that, yes, she is now a hip patient. And so the importance of blood glucose, again, I'll have to reiterate, and I'll have to tell her the risks of fetal hyperinsulinemia and the standard, fetal anomalies, as Dr. Sumitra Yadav has already mentioned. And of course, the genetic syndromes for the baby because of the higher risk, and the role of diet. Exercise cannot be overemphasized. We'll have to tell them again and again about the controlled carbohydrate intake, and 25% protein and 20% fat, and exercise of at least 40 minutes in the morning and 40 minutes in the evening. And the stress should again be on proper carbohydrate intake. And yes, deal with the denial is a big huge thing for us in India.
So basically, why I put the slide is that whenever you get an abnormal sugar or abnormal 75 GCT, please spend 5 minutes for the lady to make her understand what we are dealing with. What we have discussed all throughout this program or in any forum in JDM, this high blood sugar going to the baby is going to affect the baby. In short term, is going to cause macrosomia, excessive weight gain, hydramnios, complications during delivery, higher operative delivery rates, etc. Plus, we have to tell her that this baby's organs will get programmed so the baby can become diabetic in future. And believe me, this is one thing, if the patient gets it into her head that this high sugar is going to harm my baby, she will do her best to comply with your treatment and get the sugar down to normal. So it is important to spend that 5-10 minutes with her, because initially the reaction is हमारे तो पूरी फैमिली में किसी को डायबिटीज नहीं है, आप क्या बोल रहे हो कि मेरे को डायबिटीज है, ये तो प्रेगनेंसी में है, प्रेगनेंसी के बाद थोड़ा शुगर निकल जाएगा. And when she goes home, her mother-in-law and mother and everybody says no, डॉक्टर को क्या मालूम. But अभी जो urge है उसको पूरी करने की मतलब बेटा असर पड़ेगा, औलाद पे असर पड़ेगा. So basically, a lot of myths are associated with teaching during pregnancy.
You're not audible, Dr. Uday Thanawala. You're not audible.
Is it better now?
Yeah.
Yes.
Yeah, sorry, I think my hand was in front of the mic. So basically, we have to deal with the denial and deal with the myths which these people have about diet in pregnancy. So it is important to
Not audible, sir.
No, it's better. We can hear you, sir. We can hear you.
Oh, I can take the...
No, it's clear, sir. It's clear.
So basically, we need to deal with the myths and the denial and counsel them properly before we start even telling them about the diet and the exercise. So, first step is a healthy diet, like Jayashree has already said.
All others, please mute.
Somebody needs to
All others, please mute.
Mr. Arjun, please mute them.
ಅಂದ್ರೆ ಅವರು ಕರಳಿನ ಡಾಕ್ಟರ್ ಸರ್, ಅಂದ್ರೆ ಗ್ಯಾಸ್ ಪ್ರಾಬ್ಲಮ್ ಏನ ಇದ್ರೆ ಅವ್ರು ನೋಡಿ ಹೇಳ್ತಾರೆ.
Mr. Ajay?
Ma'am,
Please mute yourself.
Can the host mute, please?
Anyway, let's get on this medical nutritional therapy. And so how much time will you give her for this diet and exercise? And how will we monitor her sugar after that?
The host needs to mute that person, otherwise it's not going to continue. Please mute everybody.
Half the plate with vegetables, 1/4 with protein, and only 1/4 with the main chapati or rice or wherever. And we need to, be culture sensitive. We cannot advise a South Indian to eat only chapatis or a North Indian to eat only rice and quinoa and, stuff like that. We need to be culture sensitive also.
So as Hema was saying, we at least in Bombay, we have this luxury of having a dietitian. I've got a dietitian attached to my hospital for the last 12, 13 years who do my antenatal class. So I refer it to them and they tell, but it's a luxury which we have. It is not possible in all places. So one has to, as a gynec, we have to have this basic knowledge about diet. And today, believe me, nutrition is coming up as a very, very big thing in obstetrics. So we have to know what exactly to tell them, how to counsel them, put these charts up about the size of the portions, how much is a hand, the palm, so how much palm size food they should have, how much protein they should have, and what they should avoid. So it is important to know about this diet counseling, and exercise has become a very big problem with the lockdown.
Sorry to interrupt.
You can definitely tell them to walk for at least 10 to 15 minutes after every meal. And then when will you do the sugars? Once you have started all this medical nutrition therapy, physical exercise, medical nutrition, medical therapy, and insulin therapy has been elaborated by Dr. Muralidhar. So, Charmila, how good should be the sugar control, and what are your target values?
The target value for fasting should be 95, and for postprandial, it's 2 hours postprandial is 120. She has to be clearly told that, and she needs to monitor herself. That's much better than coming to a clinic and wasting her time there. So give her a glucometer, tell her how to use it, and she has to monitor her. But she's just on medical nutrition therapy. She will need to test her once in 15 days according to the Government of India guidelines. But if she's so obese and her sugars are high, I would like to do it little quicker so that she knows her control. And already the pregnancy has progressed so much, it's better if she controls before she lands up with hydramnios or with the macrosomia baby.
So how many of us put our patients who are in this range of having a 75 GCT come at around 160, 170, how many of us will put them on a self-monitoring of blood sugar among the panelists?
All of us.
So I'm so glad about this, because initially it used to be jisko insulin de rahe hain usko hi self monitoring karne ki zarurat hai, and we have changed from that time, because if it has become cheaper, it has become easier. And what I feel is that even if this lady does 3 to 4 readings every day, she herself gets educated कि आज मैंने ये खाया तो मेरा sugar इतना बढ़ गया, so she automatically and avoids that particular thing. So it is important to do this. And how good should be the sugar control? Of course, Charmila has told you the values, but something which I can never always go without quoting is what Dr. Professor Sunil Gupta from Nagpur says. The fetus in utero should not come to know that the mother has got diabetes. Your sugar control should be so good that the fetus doesn't come to know that the mother has got diabetes. So try and control the sugar levels to...
It's a utopian dream for Indian mothers. They never seem to achieve that.
They can. Very, very often, if your patients understand what they're dealing with, they will, and the target is to get a baby weight between 2.5 and 3.5, so that this baby is not programmed in utero to get diabetes in future, So... Dr. Dolly Mehra, anything more about the antenatal care?
So from the very beginning, emphasis on diet control, exercise. What I do is I sit and make a diet chart for the patient. At the same time, I start explaining her. So she gets into the habit of making this self blood sugar monitoring and the diet chart. Then, you know, all the investigations, the renal function test to check for the diabetic nephropathy if she's developing. Then the thyroid assessment test is very important. Liver function test is very important. If she's very heavy diabetic, then even fundus examination has to be emphasized.
Yeah, you're talking
The
about
antenatal visits have to be every 4 weeks till 20 weeks, and then every 2 weeks till 28 weeks. And after that, it should be a weekly visit, so that, you know, you can have a talk with the patient, and you can just talk to her so that the control of sugar is very good. You also have to take into account if she's developing some UTI or some anemia or some sort of infection, because that way she will be getting prone to getting into ketoacidosis if her sugar rises during the antenatal period.
Sorry, sorry to interrupt. You are talking about a diabetic patient, a patient who's got hyperglycemia in pregnancy from the very beginning. But they are more prone to getting nephropathy and retinopathy and ketoacidosis. The case we were discussing is a regular GDM patient who in the second trimester has developed slightly abnormal.
So in the second trimester, sir?
Yeah, it's important to keep all these things in mind. But it is important to monitor the sugar, look for comorbidities, and of course, how often will you monitor the fetal growth by ultrasound? And believe me, in COVID times, I don't call them every week. I tell them, you email me your reports, your glucose monitoring, self-monitoring chart, you better email to me so that I can comment on that. Of course, it's abnormal, you call them and you deal with it. But in general, we have to monitor the sugar level, like you correctly said. And we have to look out, monitor the growth of the fetus. So
yeah, at 28 to 32 weeks, you should get a Doppler examination done so that you pick up PIH, or if there is a growth retardation or she's developing polyhydramnios, that also can be taken care of. Yeah. And following that, you know, these patients, they do need twice, every 2 weeks, they need some NST or a biophysical profile, which is very important to check for the fetal well-being. If there is IUGR or if there is a polyhydramnios, either way.
Okay, great. So does LICA really help you in monitoring?
Yeah. See, if the LICA is less, if she's into IUGR, if the LICA is less than 2, it's a very ominous sign. And if the LICA is more, that also is causes difficulty in the fetal surveillance. So, you know, you don't have an ideal fetal surveillance modality. So you have to combine. You have to talk to her regarding the fetal kick count. You have to talk to get her NST done, biophysical profile done, and if feasible, Doppler done. Even the Doppler doesn't predict that there will be a bad outcome. That is important. If she's IUGR, of course, the Doppler will help us. But then a sudden IUFD cannot be predicted even by a good Doppler in cases of GDM.
So over here now at 30 weeks, Dr. Sumitra Yadav, we have discovered that she's got hydroamnios. The ultrasonologist has reported she's got hydroamnios. So what all will you do?
Obviously, her sugar is uncontrolled. So definitely we'll put her on a self-monitoring of blood sugar, and we'll start her on therapy. Either insulin, which I would prefer personally here, because right now we don't have time. She's already 30 weeks and there is hydramnios. That means that the placenta is large. There is every chance of the baby going into macrosomia and sudden intrauterine death. So we definitely need to control her sugar right now. Although metformin has an edge that they say that it is very, you can say it acts like it adds on to the insulin therapy. But I would, in this particular patient, prefer insulin.
Yeah, so we agree with you, because if you develop hydroamnios or you suddenly have a higher AC with the baby going into hydroamnios and she's only on diet and exercise, you definitely would want to probably start insulin so that the sugar is controlled faster and not much more damage is not done to the baby. Will you give us steroids?
Yes, sir, because we know that as such the development of surfactants in the fetus is delayed because of the act of insulin. It antagonizes the effect of cortisol. So definitely we must give the steroids, because already there is hydramnios. She can land up in a prom or she can land up in a preterm labor. Therefore, we must give her a cover of steroids. either by betnesol or by decadron, depending on the dose. That is, of betnesol, the dose is 12 milligram in 2 doses that are 12 hours apart, or intramuscular dexamethasone, 4 doses, 6 milligram, 6 hours apart. And because of steroids, that can be a hyperglycemia. Yeah. Yes, sir.
No, you put the patient on insulin. So how do you titrate the insulin dose with the steroid?
Because of the steroid, there is a hyperglycemia, and therefore you must increase or titrate the dose of insulin with the dose of the steroids. After the first dose of steroids, you must increase the insulin dose by 50%, and this increase should be maintained till 12 hours after the second dose of the dose of betnesol.
So be aware when you give steroids. Don't hesitate to give it in a diabetic. Sometimes if the sugars are not under control, you may even have to admit her and give her so that you can monitor the sugars and let her not go into hypoglycemia. Also monitor the baby, because sometimes these babies don't do very well. You know, patients complain of decreased movements after giving steroids, and also you may have to do the Dopplers again. So monitor these babies carefully when you are giving steroids.
So there's one more thing that I would
sure.
like to add here.
Yeah, sure.
That we must, if possible, because this you have suddenly discovered at 30 weeks, we must also, if we can, if she's hospitalized, do the 3 a.m. Glucose levels, because we that can be predicted for either Somogyi or Down's phenomenon, because we tend to lose babies all of a sudden in these diabetic women.
Okay, yes, that point well taken. So basically, when insulin is advised, when is insulin advised, Dr. Jayashri?
Whenever
Which
the
cases?
fasting
This is
is
one
higher
case,
than
like we said, you discover something, you start insulin. What other cases you can?
Yeah, apart from that, like this case we had macrosomia, or the patient is not well controlled with diet, exercise and metformin. If her fasting is higher than 120 and her postprandial higher than 199, and in a high resource setting, as we're all in cities, all of us who are practicing right now in this panel, I would rather that the patient, this patient has a, she does her monitoring every day, like,
Self-monitoring is important when you put the patient on insulin, or if the sugar is very abnormal.
This patient certainly, needs insulin, and she needs to be monitored more frequently.
Okay. Now we were talking about IUGR also. So there's a primary with a BMI of 29, means she's not really obese. GDM was picked up at 26 weeks. Now you said diet karo, exercise karo, or metformin bhi dala tha because sugar control mein nahi aa raha tha. At 32 weeks, you get an ultrasound report done. The baby is 30 weeks. You know, the abdominal circumference is just 29 weeks. So it is a lag of 2 weeks, and the liker is marginally less. So Dr. Charmila, this patient comes to you. So she's very worried that the baby is small. The mother-in-law is telling her कि तुम बोला sugar नहीं खाने को, अभी बच्चा छोटा हो गया है. How do you explain to her?
Very difficult situation to convince a mother-in-law now, because she'll definitely blame me for all that. So I have to sit down and talk to her and tell her if she had not controlled her sugars at least to that level, the problem would have been worse. And she could have even had an IUD even before it was diagnosed. And the other thing is there may be a vasculopathy factor now, because unless vasculopathy happens, it's very rare for a gestational diabetic to have a growth restricted baby. So that vasculopathy factor has to be kept in mind. But you said her BPs are normal. Sometimes she may go for PIH also after the growth restriction is set in. So to be very careful in your surveillance of the mother also, because she may land with hypertension.
So will you ease out the sugar control?
No, definitely not. She needs to be
on the metformin.
No, metformin, if it's there, let her continue, but insulin also will be continued to control her sugars. I will not add all this cocktail, sir. Protein, sildenafil, arginine, bed rest, because none of that is found to be of any use. And monitoring the fetus is very, very important now. Your surveillance protocol has to be set in very clearly, because it's a very difficult situation where the mother is diabetic and she's having a growth restricted fetus. So your surveillance will start with a Dopplers now. And your umbilical artery Doppler is the one which is going to help in the surveillance of this fetus. It has to be properly done. And once if you're diagnosed if the levels are normal, that the Doppler umbilical artery Doppler is normal, and if the growth restriction is between 3 to 10%, then I will do a weekly Doppler. But suppose it's less than 3% and it's a severely growth restricted fetus, then the Dopplers have to be done more frequently. And suppose there's an absent diastolic flow, it has to be like done twice a week at least. If it's going to be reversal, she will be admitted and hospitalized. If it's reversal, admitted, hospitalized, venous Doppler needs to be done now to decide the delivery of the baby now.
So this is a very important point which has been brought out, is that once you have an IUGR baby, even if it's a diabetic baby, it is not because of the sugar which you have controlled, it is because of a vasculopathy which is present there. Maybe the placental vasculature is such that the baby is not getting enough nutrition. These are the babies which you monitor by Doppler very carefully and find out when they're going to decompensate and deliver before that decompensation occurs or a problem occurs. And these are the babies who will definitely do well with steroids beforehand. And you have to think of all these things when you pick up a small for gestational age baby. What happens in a large for gestational age baby, Charmila? What about the Dopplers in large for gestational age?
Dopplers may not be of much of use in large for gestational. You have to take a risk with that. But the fetal surveillance has to continue as per protocol, depending on the flows which you see, but may not be of much use like in a growth restricted baby.
Okay, so in the IUGR baby, the Dopplers will decide when to deliver. Otherwise, Dolly, you have this patient of GDM. What is the timing of delivery, Dr. Dolly, which you undergo? Because there was a question in the chat box that will you deliver at, I think, 38 weeks or 37 weeks or something like that in the chat box.
So if there is a good glycemic control and if there is no uteroplacental insufficiency, we can wait till term for her to go into spontaneous labor, although the NICE guidelines say to deliver it at 38 weeks. But if there is IUGR or there is associated PIH, then we need to consider delivering the baby earlier.
So
and moreover, if there is macrosomia, if there is polyhydramnios, if there is fetal distress, then we can consider, or if there is again elderly primary gravida, if there is a bad obstetric history earlier, then we need to go in for a cesarean section. Otherwise, if the average baby weight is normal, then we can consider her going into spontaneous labor.
Okay, so spontaneous labor, one can wait till even 40 weeks if she is just a GDM on diet and exercise control and the sugars are absolutely under control and the baby's parameters are all normal. But generally, if the sugars are a little bit haywire or not under control, or if the baby is becoming a little big, means even if the baby weight is more, it is better to interfere earlier. And we obstetricians are very scared of a sudden stillbirth in GDMs after 38 weeks of gestation. So what are the investigations which will help us in preventing stillbirths, Dr. Sumitra Yadav? You'll have to unmute yourself, Sumitra.
As of date, it is very difficult to predict any stillbirth by the available antepartum fetal surveillance tests that we have. Because all of us have known that in the morning the fetus is absolutely all right, and by afternoon you find that there is a fetal demise despite the fact that you have got the test done. We know that if there is fetal hypoxia or maternal hypoxia consequent to maternal hypoglycemia or maternal ketoacidosis, maternal infections, maybe even UTI or even any other cause like electrolyte disturbance because of vomiting, any of these causes can be adding to that insult leading to a stillbirth. But if you actually think about the biophysical profile, you have to be very careful because the fetal tone that comes at the end, if you see that if there is a loss, then you must always become alert in such cases. If the liquor is less, that you must be careful about.
Yeah, so there's nothing which will prevent, nothing, no investigation will tell you that this baby is going to go bad unless it's an IUGR baby and you're doing the Doppler studies, etc. Sometimes
in absence of vasculopathy.
That is why most of us prefer to deliver at around 38 weeks. So even the NICE guidelines say discuss delivery at 38 weeks. But in general, the Government of India guidelines say well-controlled case, you can go up to 39 weeks. But if there are risk factors, one can definitely deliver as and when required. So points about care during labor, Dr. Jayashree Shira, the monitoring has been, the sugar monitoring has been told by Dr. Pai. So what about the other part?
So that insulin sugar control, he's already told us. So once this, we've allowed her to go into labor after monitoring her so much, and monitoring her, we need to give her a good outcome. So first and foremost, I'll get my team ready, my anesthetist, my pediatrician, and maybe another colleague. We do a team practice over here, and we all revise the drill for shoulder dystocia if everybody is ready. And the intrapartum, of course, glycemic control, sir has already discussed. We need to be more stringent on the partogram, and maybe more, to err on the side of caution. Maybe I'll be more, the typical, especially in the second stage, I want to avoid a difficult second stage, and I will not wait for the turtle sign to come to, take action. So in the earliest, I find that there is cervical dystocia, the dilatation is not happening, or the descent is more than normal, I will definitely take action. And I've already informed the anesthetist and the OT, and I have taken her layouts. And my neonatologist is also cautioned. So these are the things, and I give her
avoid doing heroic things, because we are worried about the baby also. We don't want the baby to get any injury, because it's quite a drastic injury which the baby can get. So avoid heroics, and of course actively manage the third stage of labor. Because of the over distended uterus, these women are likely to go into PPH. So with that, we come into the fourth trimester. Charmila, what do you advise her after she delivers?
After she delivers, we will be checking her sugars after the labor, and then check out whether she's returning to normal, and then call her again after 6 weeks to check whether she has continued maintaining her levels, because many of them become frankly diabetic after becoming a GDM. So at 6 weeks, I will do a fasting along with the OGTT. I will not do just an OGTT now, because fasting will need to be done, because pregnancy has gone. Yes. So the postpartum, the postprandial sugars will not be very useful in picking up the diabetic. So I will do a fasting along with an
OGTT to be done at 6 weeks, 6 months, and once a year.
Once a year. And it's very important that you talk to them very clearly now about the intergenerational transfer. So we have to tell her that she has to maintain her sugars well. And the other thing, her metabolic syndrome features are going to become much severe because she's become a GDM. Even if she controls her sugars and if she does not control her sugars and the metabolism is not maintained, she's not going to land up with all the other features of metabolic syndrome like dyslipidemia, hypertension, and all that in her future. So she has to be counseled.
To bring out the
breastfeeding.
Of breastfeeding. That will help to control the sugar as well.
And with such high sugar, she should not become pregnant again. So contraceptive advice is mandatory. And PPI-ISUD should have actually told during the antenatal period itself, and that you can put even for a diabetic.
That's a very important point which you brought out. In the antenatal period, you talk to them about this, because I think that's the only way we can improve the recall rate of this group. Because once this girl delivers and she goes home, they are just, most of them are lost to follow up. The callback rate is very, very, very poor. Just hardly about 10% come back to you with a sugar reading and say, oh, you had called me at this time for checkup.
No, like Jayashree, we scare them, sir, so they come back.
Good. So there has to be something, it has to be drilled into the head. So I tell them at every antenatal visit that whatever you've started now, the exercise and diet, you are not going to give it up after delivery. You're going to continue that. You're going to continue to monitor your sugar properly. So make sure that you don't become a diabetic in the next 5 years. So I think until we drill them into the heads, it is very difficult. Any other ideas from any of the...
So diet control and exercise should be a habit rather than just a part of pregnancy care.
Yes, that is what we have to tell them. And some people have tried to now put, on the vaccination card of the child, they put in a bindi or a dot over there, so that the pediatrician knows that this is a child of a diabetic mother. So he tells the mother, okay, get your sugars done. It has been 6 months since you've delivered. So something like that, we have to develop a system so that the recall rate of this group is very good, because it should be there. With that, I want to give one more very important discussion of one another case. Of course, this is before the woman becomes pregnant, she has to make sure she's not a diabetic, and if she's diabetic, she has to control the sugars, because these are the data which says that in India we have many young diabetics. It is not so in the developed countries. So basically, let me take this one case quickly over here, because I think we have around 10 minutes. 31-year-old gravida for abortion to ectopic 1 presented with 26 to 27 weeks of gestation with intractable vomiting and upper abdominal pain. Her RS and CVS was normal. Her BP was normal, and she had a BMI of just 23. So in spite of symptomatic therapy, the pain in upper abdominal did not decrease, and she became breathless and had tachycardia. What will you think of
acute pancreatitis or an abdominal aneurysm?
Yeah, so that's what you initially think of, Charmila. So we said, okay, we can't manage this in our setup, so we transferred to the NICU.
Oh, ketoacidosis.
Blood sugar ketoacidosis. 486. So she was in gestational diabetic ketoacidosis. So what are the precipitating factors for diabetic ketoacidosis? Anybody?
Dehydration, infection, intractable vomiting, diarrhea.
So please remember, any diabetic becoming pregnant, or a lot of vomiting, hyperemesis gravidarum, infections, insulin non-compliance, anything can push them into diabetic ketoacidosis, because it is not only something on paper. We do get cases, and the reason why this particular case happened was because she had only one random sugar done in the first trimester, and after that nobody had bothered to check her sugar at all, and only one random sugar done in the first trimester and nothing done after that. So basically, these are the presentations of diabetic ketoacidosis, and this is of course that is why the Figo guidelines say that us we should test for the sugar first at booking, and then again at 26 to 28 weeks, and in the third trimester if required. So what are the complications of diabetic ketoacidosis? Anybody, Dolly or?
So she can go into cerebral edema, or she can also go into an ARDS with diabetic ketoacidosis.
The baby may die. There'll be an IUFD.
IUFD.
Yeah, IUFD. Now that's important. So what is the effect on the fetus? What is the effect of ketoacidosis on the fetus, Charmila?
There will be the baby will go for distress, and it may even have a mortality inside. That is quite common in severe ketoacidosis.
Yeah,
the ketones are very toxic.
Yeah, ketoacids as well as glucose readily cross the placenta. Maternal acidosis, hyperglycemia, severe volume depletion, and electrolyte imbalance all have a detrimental effect on the fetus. The fetal mortality associated with diabetic ketoacidosis ranges from 9% to 36%. We don't know what the long-term effect of diabetic ketoacidosis is there on the surviving fetuses, but some studies have shown a direct relationship between plasma ketone levels in pregnant and diabetic women and a low IQ in children. So basically what happens is, when you do an NST over there, you may get a lot of changes when the patient is in the diabetic ketoacidosis. And this is often corrected when the maternal hydration and acidosis is corrected. And normalization of fetal heart racing can occur after correction of the diabetic ketoacidosis. So biophysical profile and Doppler studies may just reflect the fetal acidotic stage. So should we deliver this patient, any of the panelists?
No need, sir.
No, sir.
No need.
No, sir.
Metabolic disturbance or electrolytes.
So there's already a lot of problem happening to the woman. So basically, sometimes from the NICU you get a call, "Arey, diabetic ketoacidosis, bachche ko nikalo." But then the problem is, you may worsen the situation for the woman. And interestingly, once hyperglycemia and acidosis is reversed and maternal stabilization is achieved, fetal compromise may no longer be evident. But the decision of delivery should be individualized and should be primarily based on the evaluation of the maternal clinical status to ensure a safe labor and delivery, and the gestational age also needs to be continued. So how do you, this patient has come to you, what do we do in our setup before we send it to the ICU for diabetic ketoacidosis?
Correct the dehydration. IV fluids is most important, and start insulin, of course.
Yeah,
so IV insulin.
Excellent. So IV fluid and insulin therapy and electrolyte balance correction is important. And of course, one has to remember that when you when you start insulin, the potassium should be more than 3.3, because if the potassium is low, it will create problems. So it is better to have the electrolyte imbalance corrected and the patient hydrated and then start IV insulin. So basically this patient landed up with a IUFD, but the patient recovered and did well. But basically it is a complication which we should be scared of. And we should therefore realize, especially our diabetic patients, we should tell them very categorically to maintain the sugar and maintain the insulin intake if they're on insulin, so that they don't land up with diabetic ketoacidosis whatsoever. So thank you all very much for this very interesting interchange. And any other comments or chat box? There's one thing on the chat. Dr. Aditi Rathore has said, any level of HbA1c where we offer termination if the OGT in the first visit is normal, do we need to repeat it?
No need. There's no need to repeat a HbA1c because there's a physiological dilution happening. So the glycosylation of the hemoglobin will not happen in the second trimester onwards. So there's no
the question
point
is at what level of HbA1c we offer termination.
No.
Well, we don't generally offer termination. We just make them aware of the risk which they face if the HbA1c is high. And if the OGTT in the first visit is normal, do we need to repeat it? Yes. If the first visit is normal, we have to repeat it definitely at 26 to 28 weeks, because that is when the diabetic changes will come. Nowadays, we are also saying repeat at 32 to 34 weeks, but that is of course optional. But we definitely want to repeat an OGTT in cases where we pick up hydroamnios, in cases where we pick up a abdominal circumference, etc. In those cases, we will definitely repeat an OGTT. Any other?
Or if there has been a BOH case, like if there has been a previous pregnancy, if she's had an IUFD, there also we have to be very careful in the third trimester as well.
Excellent. So repeat it often if you have to. An elderly primary at 24 weeks OGTT, fasting sugar is 100, 2 hours is 159, after diet and exercise after 10 days, fasting is 90, PLPS is 117. But she develops polyhydramnios and the AFI is 27. How do you manage further? HbA1c 6.5 in the early trimester. Yes, who's going to answer this?
The monitoring is not correct. The sugar testing which is done is not enough probably. The polyhydramnios tells us that the control is not good. So she may be actually admitted for a day to check out how her sugars are. So at least the 6th level, you have to do at least 6 times to check out which levels are high, because unless there's sugar which is not controlled, she's not going to have hydramnia. So that is an indicator. The sugars need to be controlled much better.
Yes.
So and we need to check that target scan or the level 2 scan was also done. Otherwise, sometimes, the level 2 scan has been missed and she comes directly at 26 with polyhydramnios. We don't know. She can be having an abnormal child also.
Exactly.
Fetus
so
also
find
inside.
out other causes of polyhydramnios, any structural abnormality which we are dealing with, or it could be from the placenta. If the placenta is large and thick, that could also cause polyhydramnios. But Charmila has got an important point. Do a proper self-monitoring of blood sugar, and this patient you may need to start monitor her sugar properly before you start any anti-diabetic on her, only for the polyhydramnia. So it's a difficult situation, but rule out other causes also. So I think that's about it. At what blood sugar level insulin should be started? I think we've covered that, correct?
So there are a few more questions in the chat box. If you allow, can I take them from the first?
Yeah, please. Yeah, please.
Dr. Leela Joshi ma'am is asking, to what extent a mother can undo the tsunami of diabetes, which is expected very soon in our country?
Yeah, so any panelists would like to answer that?
They have to listen to the gynecologist first. Then only the tsunami will stop. If she's not going to listen, the tsunami is going to go on and on. It's not going to stop anytime.
Yeah.
Dr.
So I think we will counsel the patients.
Counseling is very, very important.
Dr. Manisha is asking, any documentation or consent required before starting metformin?
No.
No.
Frequency of blood sugar testing during insulin therapy?
It could be in self-monitoring from 6 to 7 times in a day to then initially, and then it can be reduced to 3.
I would do a fasting and then
three postprandials. So that will tell us, because
lunch and dinner. Yeah.
GDM is basically postprandial elevation of sugars. It's not much of the preprandial levels, which will happen in a diabetic mother. So in a GDM, it will be more of fasting and 3 levels. And once she controls, you can actually reduce it to once in 3 days, because she's not going to be compliant if you tell her do it every day, like in an American college guideline. For Indians, you need to taper it like to once in 3 days, because as sir was saying, if you can tell her like how she's controlling, she will know when to avoid that type of food. So that's why the monitoring and the counseling needs to go together, so that you explain each point to her.
Dr. Dona is asking when to start 6-unit insulin in drip. Is there any cutoff blood sugar level?
That is after 180. That is after 180.
No, she's talking
180, and that also in labor. That was in labor.
Yeah.
The IV insulin was in the labor, during labor.
In that 6 units is just to control the sugar which this particular unit will raise. It is not to correct the high sugar. It is just
to neutralize the
just a maintenance dose of insulin that we are starting. And after that, he said that if it is more than 180, then you need to add 1 unit to this 6 units. There's also another question about how many days metformin usually controls blood sugar. Well, metformin, I think anybody would answer that. I think it takes about 6 to 7 days at least to have its effect.
Yes, sir. At least 7 to 10 days before you can see a control, like in a nutrition therapy also. So 15 days of therapy, like that, metformin also 15 days at least before you can check the levels. But they also have to monitor their sugar levels. You cannot say there's no need for monitoring when on metformin therapy. And the advice with the Government of India guidelines is at least do it twice a week until she controls with metformin. And then you reduce the level of monitoring. Otherwise, she will not know whether she's controlling with metformin. And diet and exercise has to be emphasized along with metformin. Just giving metformin is not going to be useful at all.
Excellent. Now, one very important point, if GCT abnormal in the first visit, why it should be repeated? She will be labeled as GDM in the first visit. Yes, if she is labeled as a GDM in the first visit, please do not repeat a glucose challenge test. Even, in fact, sometimes the patients
just sugar monitoring
when we tell them that 10 din ke baad phir se sugar ka karke aao, they again drink the glucose and do it.
No,
not required. Then you have
not
to monitor
required.
either by fasting and post lunch, or you have to do a self monitoring of blood sugar. If she is labeled as a GDM, she need not take the glucose challenge test again.
Yes.
You may make her a ketoacidotic if you give her glucose and then.
Somebody wants to know the doses of insulin again. I think we just elaborated the doses, or anybody wants to say it again?
So what Dr. Pai sir said seemed very reasonable.
Very nice.
Actrapid thrice a day, 4 units, and then add a NPH at bedtime for the fasting sugars. And then once she's controlled, you can actually advise her to change over to a mixta twice a day, which seems to be very reasonable way, because at 0.7 units per kilogram seems to be a very high dose for a GDM mother. And they go for hypoglycemia, and which may affect the baby also, because more than hyperglycemia, the fetal hypoglycemia may be more dangerous to the baby. So I think that seems to be a very reasonable dose which sir has said. You can follow that type.
But sir also said that the endocrinologist advises another unit of long-acting insulin at bedtime.
Yeah, that's what, Dolly, that has to be taken at bedtime, and that's for the fasting hyperglycemia which happens. And that he said is because of the hepatic gluconeogenesis. That's not because of the diet. So you need to control the fasting sugars, because that's the reason for the stillbirth which happens, the unexpected stillbirth which happens. So it's why seems to be very reasonable regime which he said.
So we start dextrose 5% and then neutralize it with 6 units of insulin. So why give dextrose? Why not give other fluids like?
You can give ringolactate.
No, it's a neutralizing drip. We want to avoid a.
For neutralization, you have to give dextrose. Otherwise, you can give
ringolactate. So that was the question which came up. Should 6 units insulin drip be started in all laboring patients? Only if you want to give glucose, add the 6 units of insulin. Otherwise, you can give ringolactate if your patient is reasonably well controlled and doesn't have a very high sugar. It's fine.
Right.
So one question is there: baseline and organ workup for mother.
I couldn't understand that question.
So at least they need to check for the diabetic nephropathy, the retinopathy.
Dolly mentioned it, yeah.
That is not for a GDM.
Retinopathy, these pregnant patients, so they definitely need a retina
evaluation.
If you have a diabetic patient who's already diabetic and becomes pregnant, then you have to definitely look at all these things.
And there was something interesting which I read, that if there is a diabetic patient with a progressive retinopathy,
Yeah, yeah.
If you have checked, then they should not be allowed to go into labor, because then she will land up into more trouble. She should be taken up for a cesarean. If there is a progressive retinopathy in a diabetic patient.
So overall, we've been very optimistic on metformin. One word of caution here on some patients, you know, like if they're already having these fatty liver and these obese patients, we need to be a little cautious when we are using metformin, and, you know, tell them that when they have loose motions repeatedly, to contact us, because, you know, some of them could go into some toxic hepatic failure, or, you know, there have been cases reported. So they
I
have
had one patient who just could not tolerate metformin. So sometimes they just can't tolerate.
Don't tolerate, right.
But
And,
yeah,
you can gradually start and increase the dose of metformin in that case.
So fetal echo, best time to do technically 22 weeks.
22 weeks.
Technically 22 weeks, but even at 18 to 20 weeks, most of our sonologists
You
are
can.
pretty confident of what they are telling us about the fetal echo. But technically, they say at 22 weeks you repeat an echo anyway. So that
Because at 22 weeks you can find out minor defects that
Minor.
you miss at 18 to 20.
So I think we've covered most of the things. Anybody else has any comments? Any?
Yes, sir.
It was excellent. You have had a very good question. Really, thank you.
Well, the topic was such, it was basically practice points. So I didn't want to go too much into any other
Thank you,
thing.
sir. Thank you,
It
sir.
was basically telling you basic GDM patient aaya to itna to karna hai, and that is how you just move forward.
Thoroughly enjoyed.
Thank you so much.
Well done, ma'am.
Thank you,
And
sir.
thank
Really
for all
very
your
practical,
input.
sir.
The flight of our webinar today on
And
GDM.
really, hats off to Ratlam Society. I'm very happy.
Thank you, Didi.
Nice.
But very nice discussion. We all enjoyed. पूरा practical points बहुत अच्छे से cover किया सर आपने.
Thank you very much. Thank you
Yes,
very much.
all that theory before.
Thank you.
Having me here.
Panelists,
It was a
thank you.
pleasure
Sumitra
being
Didi,
here.
Dr. Charmila, Dolly,
One
Jayashree,
Thank you, Didi.
thank you.
Just 1 second, sir. I would like to call upon Dr. Aditi ma'am for vote of thanks.
We would like to thank the moderator,
And
Dr.
do you
Uday sir,
prefer
for the
delivering at 37 weeks or go up to 39 weeks? I think we have answered that.
Dr.
Okay, please.
Yes.
Thank you, sir.
Good
Before the
evening,
vote of thanks
everyone.
starts, thank you, Dr. Uday sir, for the opportunity.
Thank you, Charmila. You've been always a great help, and very good to have you all on the panel. All our panelists have been excellent.
Thank you so much, sir. Thank you,
Thank you,
Dr.
sir.
Manish and Dr.
Good evening, everyone.
Just 2 more minutes, ma'am.
Hi, Uday.
Aditi ma'am, welcome.
All working very hard, yeah.
Good evening, everybody. It has been a
Leela ma'am,
fabulous
good evening.
evening. Indeed,
Ah,
an
good
academic
evening.
fest.
Good
Hi, it
evening.
was a very
evening.
nice panel.
Good
Uday,
evening.
congratulations.
Thank you very much. Thank you.
हाँ सबको खींच दिया कि GDM
नहीं,
तो
मैं
पढ़ना ही पढ़ना है.
Couldn't recognize you without your hair there.
Dr. Aditi ma'am, your voice is not very clear.
I'm proud to say that I'm Dr. Leela
Yeah.
Vyas'
Is it audible now?
student.
Yes, ma'am.
And I am always proud that my students are working very hard.
Yes.
सब कहते हैं ना नाम रोशन कर रहे हैं.
Thank you, ma'am. Thank you so much.
Yes, Dr. Aditi.
Yes, ma'am. It has been a fabulous evening, indeed an academic fest, and raised by none other than stalwarts of OBG in India. It is indeed my privilege to extend my vote of thanks on behalf of Ratlam OBG Society. My heartfelt thanks to President AMPOGS, Dr. Jyoti Bindal, and Vice President AMPOGS, Dr. Yashodhara Gaur, and our own very dear President, Dr. Maheshwari ma'am, and Dr. Neha, who has been a very resourceful and energetic secretary to our society. Thank you for organizing such a beautiful evening. Now, my thanks to Dr. Jaideep, thanks sir, and Dr. Kavita Bapat ma'am for gracing the occasions. Words fall short when I think of Dr. Pankaj Desai sir, and I must say it is indeed a joy listening to him, to a person of his stature. I extend my thanks to Dr. Leela Joshi ma'am and to Dr. Hema Devekar ma'am, Dr. Devekar ma'am for tackling the tsunami of diabetes in India. The talk by Dr. Modification has been very exuberant, it has been very crystal clear, and it raised many of my doubts. I'm thankful, sir, because as you said, you tackled the basics, and if we can face our basics well, I think half of the battle has been won.
Thank you all the eminent panelists for such a wonderful panel. It has been very enlightening to listen to you all, and many doubts have been cleared. And last but not the least, my heartfelt thanks to Pharmacent for sponsoring the event. Thank you, Mr. Arjun. Thank you, ma'am.
Thank you so much, ma'am.
Thank you.
Thank you.
Thank you, everyone.
Thank you, Manisha Di.
Thank you.
Thank you, Manisha.
Thank you.
And
Thank you, sir.
Thank you, Uday sir.
Thank you, ma'am. Thank you, Dolly ma'am. Thank you.
Thank you, Smita Di.
Thank
Bye
you,
bye.
Dolly, Neha.
Thank you, Sumita Di. Bye.
Bye.
Bye, ma'am.
Bye-bye.
Good night. Thank you.
Good night.
Thank you, everyone. Bye-bye.
Bye.
Thank you, Mr. Arjun.
आज तो पूरी पीक हो गई।
सच्ची full 100 मनीषा मैम।
100 हो गए।
बिल्कुल।
बाकी YouTube पे अलग मैम।
अच्छा, हाँ, सही बात है। 100 तो हो ही गए थे इधर।
हाँ,
97 तक
बहुत सारे
देखे
लोग
थे
ऐसे होंगे
मैंने।
जो ज्वाइन करना चाह रहे होंगे लेकिन ज्वाइन नहीं कर पाए होंगे।
हाँ,
100 टच हुआ था मैम।
बिल्कुल बिल्कुल।
चली हो गई यार।
रियली था भी बहुत अच्छा।
बहुत अच्छा था मैम।
सभी लोगों ने बहुत अच्छा बोला और डिस्कशन तो बहुत ही अच्छा था।
एंड ऑन टाइम हो गया।
हाँ, ऑन टाइम बिल्कुल 7:30 बजे डॉट खत्म हो गया। चलो, थैंक यू सबको। गुड नाइट। बाय।
जी मैम, थैंक यू। बाय बाय।
बाय।